Gentlemen, authorities, students, virtual audience, good morning to all. We would like to inform that this ceremony is being recorded and streamed to our channel iea.usp.br. We are going to open the international conference, the second webinar of this series, Brazilian pandemic. It's not only a viral event. We're going to have an international outlook on how we can share the papers of researchers looking at social and human sciences. We seek to deepen the information that has been produced in a multi-stakeholder approach, including scientists, authorities, managers that wish to strengthen our unified health system and the different communities in their social response. In this virtual panel, we have Professor Dr. Roberto, Dean of the University of São Paulo, Professor Roberto Carlotti Jr., Pro-Dean in the postgraduate courses, Professor Rosalida Deus Lopes, Deputy Director of the Advanced Studies Institute at the University of São Paulo, Professor Marcia Castro, PhD, also member of the consulting committee of the Brazil Studies Program faculty, and also with the David Rockefeller Center for Latin American Studies, Professor Lorena Barbaria, professor of the Department of Political Science of the University of São Paulo since 2015, also chair of the local committee of IPSA USP, University of São Paulo, Summer School in Concepts and Methods in Political Science and International Relations, and Professor Vera Paiva, full professor of the Department of Social Psychology of the Institute of Psychology at the University of São Paulo, and Lancet Mission Health and Human Rights, founder and coordinator of the AIDS Prevention Center at the University of São Paulo. We will now hear the coordinator of the event, Professor Vera Paiva, for her opening remarks. Good morning to all, and welcome to the second seminar with the theme, the COVID-19 pandemic is not just a viral event. I would like to begin by thanking Lorena Barbaria, a colleague of the Political Science of the University of São Paulo, and Marcia Castro from the Harvard School of Public Health, and the support of David Rockefeller Center from Harvard School in organizing and putting together this event. I should underscore that this conference has been produced primarily by women. I'm very grateful for their efforts during their holidays. They serve governments and international agencies and are researchers in different fields that think and co-produce social responses to the pandemic and who have actually responded to our invitation. And I believe that we are all fully aware, as says Paulo Freire, that there is a need for a global and articulated response to this health and humanitarian crisis. I also believe that we share a great concern with the unexpected control of the Brazilian pandemic, reaching 500,000 lives, with a very high toll that has bereaved thousands of families. We're also concerned about the future for the youth that have been working in the outskirts of our cities, and the recovery, the post-pandemic recovery, and of course the need to tend for millions of orphans from the COVID-19 pandemic who have been feeling its effects in their bodies and souls. As a researcher in social psychology and preventive medicine, I have experienced intensively the first years of AIDS. I was part of the network of researchers, health professionals, and community leaders. Social movements co-produced a Praise Brazilian response much faster than in the experience with HIV. In the outbreak of COVID-19, it became clear this is not a viral event, and we have validated the multi-stakeholder and intersectoral response to the pandemic. COVID and AIDS were similar at the start in their rational, the denied science, and the first effective response that sought to test and care for the infected people and encourage education for social behavioral prevention in the psychosocial experience of fear that deepens the denial of risk and stigma associated with people, and also with protective inputs such as condoms and masks. Once again, the misuse of the notion of risk groups from the start revealed once again that social inequality is a determinant for individual and collective health. There are relevant differences between both pandemics, one being that we still do not have a vaccine for AIDS. In terms of access, as we discussed in the last seminar last June, well, there are many other differences which cannot be discussed in this conference, differences and similarities. But since we are in Brazil, I would like to emphasize one of difference which actually makes us have a firm commitment to all of these seminars. When it comes to the audience and participants that will replicate over time, thanks to the simultaneous interpretation, we can bring to the discussion researchers, physicians, and researchers that are aligned with this perspective, looking at the environmental crisis that is also key for this and other pandemics, as will be discussed further. We have produced a high amount of evidence on how the social, cultural, and political context and conservatism and authoritarianism, and these are the differences I'd like to highlight, produce the destruction of public policies and hypopandemic and hamper human rights, and of course aggravate social problems in Brazil. There's much we have learned as to how we can use health programs to mitigate inequity, inequality, and access to prevention, care, and still in context of severe poverty and unemployment, sexism, and racism, of course, produce neglect to health and denial to health and life. I would like to thank all of those who will share their research with us, their papers, in seeking to produce social cohesion and to produce change or sustain public policies to control the pandemic with the collaboration of communities and those who have been mostly affected. Community participation with lower investments than we should be seeing, and more important than ever, especially considering the tragedy we've been facing in Brazil. In the case of Heliópolis, who are joining us today, patient healthcare should belong to all or to none. I wish you all an excellent day and an excellent week. Thank you, Professor. We would like to point out and thank the following authorities: Mike Ryan, Executive Director of the WHO. Dr. Ryan has been managing health risks for over 25 years and is the Executive Director for the Emergency Health Programs at the WHO. Ed Garcia from the Peruvian University of Washington, former Minister of Health in Brazil. Jarbas Barbosa, Director of the Pan American Organization of Health, PAHO. Carlos Lula, Secretary of Health in Maranhão, and President of the National Council of Health Secretaries. We would now give the floor to Professor Lorena Barbaria, Professor of the Department of Political Science at the University of São Paulo, and she's the scientific coordinator of the Solidarity Research Network on COVID-19.
Welcome to everyone. It's really wonderful, wonderful pleasure to be joining Vera Paiva and Marcia Castro, with whom I've co-organized this event. And it's an incredibly important event, the second event that we've held, trying to promote the discussion of the pandemic is not only a viral event. Through these events and through the work that we've sought to undertake across the last year and a half of the pandemic, we've tried to encourage a discussion within the university and across Brazil, and now for the first time internationally, that in order to understand the pandemic, we need to embrace and discuss the impact across disciplines, and also academia, dialoguing with those at the front line, those that are in policy positions and in leadership positions in our society across different sectors and across multiple different areas, but also thinking about engaging the most vulnerable and those whose voices are often not heard during this pandemic. And that's been a strong commitment that we've had in organizing these events. And today it's really important that we're here broadening the discussion to highlight and to bring together international perspectives about many of the common challenges we face across the globe, but also what are specific to different contexts and different countries. And so it's a tremendous honor, and we're very, very excited to welcome all of you. And I just want to thank very much the David Rockefeller Center for Latin American Studies, who has generously provided the simultaneous translation for this event and has been a really wonderful co-organizer of this initiative. Thank you to everyone, and thank you also to Marcia for all of her collaborations with Brazil. Since the pandemic has started, it's been very important to count on your support and your work.
Thank you, Professor Lorena. Agora ouviremos as palavras da professora doutora Roseli.
We will now turn it over to Professor Rosalie, Deputy Director of the University of São Paulo, Institute for Advanced Studies. Good morning to all. It is a pleasure to be here. On behalf of the Institute of Advanced Studies, I would like to greet you all, our special guests, our speakers, and authorities, and our virtual audience, Professor Vahan Agopian, our Dean, Professor Carlotti, our Pro-Rector and postgraduate courses, on behalf of whom I would like to greet all of our colleagues from the University of São Paulo. I would also like to greet the present authorities and speakers of the event, and Mr. Michael Ryan from the World Health Organization. I would like to greet all of you who will be here today and tomorrow with us. Professor Marcia Castro. I'd like to thank the Harvard University, Rockefeller Center, our gratitude for putting this event together, such an important debate at many different levels. I would also like to thank Professor Vera Paiva, Professor Lorena, for all of the events they have been organizing, and especially this event we are opening today, two-day event, full days. The IEA is once again bringing relevant debates to the table, not only for Brazil, but at a global level, with an interdisciplinary, multi-stakeholder approach and debate that will show us how to move forward and tackle so many challenges. Thank you once again for this opportunity and for attending this session. Thank you, Professor. And now we will give the floor to Professor Carlos Roberto Carlotti, Pro-Rector of the Postgraduate Courses of the University of São Paulo Fellowship Program.
Thank you, Sylvia. I congratulate Professor Lorena for the to organize this meeting, and also Professor Guilherme Professor Vahan to support the event. At the beginning, we thought that COVID-19 was just a disease. So our problem should be only health. But now we see that COVID-19 was only a disease. It told to us that our society has many problems, much bigger than a health problem. We have social problems, we have ethnic problems, we have so many problems to think about when we see the COVID-19 in our society. So the challenge now is to change our society, not only to talk about COVID-19, but we have to change the way we deal with our social problem. So Lorena, thank you very much for the invitation. I hope you have a very nice meeting with very nice discussions, and we should also change the graduate studies in our university based on what you discuss in this event. So thank you very much, Lorena.
Thank you, Professor Carlotti. Now, anunciamos as palavras do professor Dr. Vahan.
And now we will give the floor to the Dean of the University of Sao Paulo, Mr. Vahan Agopian. Good morning to all. Good morning, ladies and gentlemen. It's an honor. I'm honored to be here. It is a privilege for the University of Sao Paulo to host this event, this debate about the pandemic on a broader level. I would like to thank our supporters today, Harvard T.H. Chan School of Public Health, David Rockefeller Center for Latin American Studies, and the organizers, Vera Paiva, Lorena Barbaria. Thank you for putting together this international event, Marcia, and we will have the opportunity to hear speakers from 14 different countries and to exchange information. Once again, I would like to welcome our speakers and thank all of our speakers, and to say that, well, activities like this are becoming ever more important, because now with the growing number of fake news everywhere and misinformation, universities, the academy have become a reliable source for the society when it comes to sharing and spreading information. Therefore, it is key for universities to actually carry out such discussions and to produce information about the pandemic that is reliable and trustworthy. I wish you all a wonderful event. Thank you. Thank you, Professor Agopian. And we are now going to close the opening ceremony. The University of Sao Paulo would like to thank you all for attending, and we wish you all an excellent seminar.
Okay. So good morning, good afternoon, good evening. I'm Marcia Castro from the Harvard T.H. Chan School of Public Health, and I'm really honored to have organized this event with Professor Vera and Professor Lorena. So we're going to go ahead and get started with our first session, and it's our great honor to have Dr. Michael Ryan, Executive Director of the WHO Health Emergencies Program. Dr. Ryan has really been at the forefront of managing acute risks to global health for nearly 25 years. He served as Assistant Director General for Emergency Preparedness in response to WHO Health Emergencies Program from 2017 to 19. He has worked in conflict-affected countries, led many responses to high-impact epidemics. He's a founding member of the Global Outbreak Alert and Response Network, which has aided the response to hundreds of disease outbreaks around the world. He served as coordinator of epidemic response, operational coordinator of WHO response to SARS, and WHO director of alert and response. He completed his medical training at the National University of Ireland, a master's at the University College of Dublin, and a specialist training in communicable disease control at the Health Protection Agency in London and the European Program for Intervention Epidemiology Training. Above all, Dr. Michael Ryan has been one of the faces of this pandemic, not shy of words of calling people when they're doing the wrong thing, which I honestly truly appreciate. So it's our great pleasure to have him here to have a conversation about many different aspects of the pandemic, aspects that we're going to go in depth during today and tomorrow. Mike, I'm going to start with a topic that I know it's close to your heart and you've been fighting this. So we're going to start with infodemics. So this is one of the most challenging problems, not just for this pandemic, for public health broadly. And I wonder if you could say a few words of how WHO has addressed this issue and how different actors in society, and you know, you can use Brazil as an example, but more broadly, how different actors can contribute to reduce infodemics. And for some countries, this is particularly tricky. If you think of Brazil, the federal government is the first one spreading wrong information and denying science. So I would love to hear a few words from you on this topic.
Great. Well, thank you, first of all, for the invitation. It's great to be with you all today. And my regards to all our colleagues around the world, and particularly to you in Brazil and in the Americas. Yes, you are right. The information overload, and it's both good and bad information. The difficulty is that people find it very hard to sift and separate the good information from the bad information. And really what helps people do that is trust. In the end, at the end of the day, the information itself doesn't change behavior. If you trust the person giving you the information, if you trust that information is in your best interest, then you will act on it. And I think that's really the deficit we're dealing with, not a deficit of information or even good information. We have a trust deficit between people and governments, between governments. And it's at all levels, as you said. It starts very much at the community level and expands and becomes even more difficult as we move up. But this is not a new phenomenon. Speakers have introduced this conference have spoken about HIV. Tuberculosis in my own country was a massive source of stigma, a massive source of misunderstanding, families ostracized and pushed aside from society. In the past, we've seen this. It's not a new phenomenon. People fear contagion. We fear infectious diseases. We're programmed to fear infectious diseases because we want to avoid them. The difficulty is in a situation of charged emotion where information is not perfect, where we don't fully understand what's going on. You have to trust the system to give you the information that you need. We've not been particularly effective in doing that in this pandemic across the board. And what that gap and that vacuum has been filled with misinformation, leaving people very exposed, not just exposed to the virus, but exposed to poor information. And it's something we need to do better at. We're trying at WHO through our infodemics approach, through our EpiWin network, through our collective service for community engagement. But everyone is struggling to do this. But I would just say, Margaret, that for me, we can do better at information management. We can do better at giving good information. But unless we bridge the gap in trust, then it's very difficult. And if people and communities have been left outside the system for decades, and the only time they see the system is when the system is coming to ask them to do things that they don't fully understand, then how do we expect people to react? We leave people outside the health system. We leave people outside the social system. We leave people outside the economic system. And then we expect them to behave perfectly when there's a crisis. And many people in poor communities look at us and say, what crisis? Our crisis has been going on for generations. This is your crisis, not our crisis.
Yeah, I think you raise a really important point. In Brazil, we commonly say that we have an invisible population, and those are the most vulnerable. And unfortunately, this population only becomes visible every 2 years when we have elections, because elections are mandatory in Brazil and the politicians get their vote. And then suddenly they become visible, but the problems are there all the time. And I think there's another aspect regarding trust, Mike, which is, and here I think all academics have to do a mea culpa, which is we don't really do a good job communicating uncertainty. And in a pandemic of a new pathogen, that the knowledge is being built as we go. And I think WHO suffered from that with all the discussion about masks and then the issue of ventilation and aerosols. The knowledge is coming. So the message can change because, one day we know more than the previous day. So can you just say a few words about this? About, sometimes you give a message and then you give a different message just because you know more. And again, I'm doing a mea culpa here because I think we still have to learn how to communicate uncertainty, and that can ruin trust.
Yes, I think that is true. But communicating uncertainty needs to be done with that sort of included in the message itself. So it's very important that scientists, when they are looking at data and looking at their analysis and their public health advice and policy, is to communicate that uncertainty. People aren't stupid. People are smart. They're much more believing of someone communicating uncertainty, but giving the best possible advice that they can. I would say, though, in this case, and certainly over the last year and a half, we've also seen a divide between science and policy. And that's where I think it's been quite difficult for communities, because we've seen quite public battles between the public health of the science community and very often government and government policy. And that has caused difficulties as well, because very often the public health community is trying to communicate uncertainty, but at times that our capacity to influence policy and the capacity for science to drive policy has been compromised by the politics of the situation.
Right. So another issue I would like to raise with you is the whole issue about universal health systems. That's one of the sustainable development targets of the goal for health. And right before COVID, so towards the end of 19, there was this global health security index that was put together, and it ranked countries such as the US, the UK, and Brazil very well positioned to respond to a new epidemic, a new pathogen circulating. In the case of Brazil, one of the factors that really positioned Brazil well was a universal health system that is, recognized internationally as being really good and as being resilient. So this concept of health system resilience didn't really not hold during this pandemic because it was not shielded from a bad leadership. And we have many different examples. Brazil is just one of them. So I wonder if you could share your thoughts on what is the possibility that we can find ways of revisiting this concept of health system resilience and really shield health systems, but also public health institutions from bad leadership?
Well, I think what this pandemic has shown, and it's a bit like the 100-year or the 1,000-year storm, buildings are constructed in earthquake zones to resist a certain magnitude of earthquake. Not every earthquake, but for 100 years or for 200 years. And health systems are constructed in the same way. Health is seen as a cost of the system. Many health systems around the world, while very good, are run at very, very low margins. They're run really on 100% of their capacity most of the time. The engine is running at full capacity all of the time to meet the health needs of populations. But there are huge inequities within that. And when people say we have a great universal health system, you go below the national level, go down to the state level, go to the local level, and you find that breaks down. And I think that's what we found all over the world, that the health system is not the same in all parts of any country. Therefore, there were weaknesses in all systems, And those weaknesses were greatest in areas of poverty, greatest in areas of social exclusion, which is not unexpected. I think the other thing, and you mentioned all these measurements and index and external evaluations and global health security index, I think you mentioned, many of those assessments are counting things. You know, they're looking at the system and they're counting how many doctors, how many nurses, how many beds, how many hospitals, how many laboratories. So it's a very static measure of capacity. It measures the infrastructural and workforce capacity. What they don't and didn't measure, I think, adequately was the decision-making capacity of the system, those dynamic parts, the trust part of the system, the governance part of the system, and how governance will interact with science and policy. And when you look at that, these intangibles, hard to count and hard to measure, the performance of the system. So if you look at an athlete and you can judge the athlete as so many feet tall and they can run a certain distance in 100 meters and they're extremely fit, but will they be okay during a football match where they have to be dynamic and face an opposition where the tactics change and the situation changes? And I think that's the difference here, is that we were looking at the physical attributes of our system, not at its strength and conditioning, not in its adaptability, not on its ability to cope when the system started to collapse. Complex systems fail in very complex ways. No more than when 50 years ago, when your car broke down, well, you had a hammer and a wrench and you got out and you banged a few things and you could get the car going. I'm sure in Brazil, people were used to that in the past, like in my country. Now you open the hood of your car and it's computers and you can't do anything. Once the system fails, you can't fix it in real time. You've got to go and get help. So I think we've built complex systems that require huge amounts of investment in resources. They're not very flexible and they don't adapt well in failure. And all systems fail at one point. And the real question is, as a system starts to fail, are there fail-safes in there that allow the system to cope? Can you move staff around? Can you change people's post descriptions? Can a nurse become a doctor? Can an anesthetist become an emergency physician? Can a renal physician become an infectious respiratory physician? Are we able to move our resources around? Are we able to manage clinical pathways? One of the big challenges in SARS-CoV-2 and in COVID is that a very small proportion of the population do very badly when they get infected. And most people do okay. And the real trick is getting those people who are likely to do badly into the system quickly and get them in front of a qualified physician and nurse at that very moment when they're likely to desaturate, their oxygen is likely to go off. And can you support that patient through that critical period? Too many patients did not get to that care in time. They couldn't enter the system. The system wasn't able to sort out the very sick from the somewhat sick from the not so sick. And the systems become overwhelmed very quickly. So a lot of this has been about the dynamic capacity of the system to change and cope and move resources around. And I don't think we've measured that adequately, and I don't think we've invested in that. And that's what you call, I think, resilience. It's not just resilience. Resilience is the ability to be hit and absorb the punch, but it's also the ability to dodge the punches and move away from the punches and avoid the hits. And I think that's, for me, resilience is a bigger concept. And we haven't thought enough about the flexibility and the adaptability part of the system.
Yeah, I mean, what you just said is music to my ears, because in full disclosure, I'm very skeptical about any of those indicators, because usually they're constructed based on what is available, not based on what is needed to go in there. They have nothing about quality. So as you said, they can look really great, but can they adapt? Can they respond if one of the components of those indicators fail? So I don't believe in any of those indicators, and I don't believe in any of those beautiful reports that come after a pandemic telling us what to do next to avoid the next one. So we have way too many of those. I hope we're not going to produce like rivers of those reports in the coming months, because I don't think that's necessarily what we need. So I want to follow up what you just said with another question, which is, we are probably facing a scenario where the demand for healthcare is just going to increase because of long COVID. And we don't even know exactly the full spectrum of demands that we're going to have because of the conditions associated to long COVID and for how long they are going to last. We have pretty solid evidence from different studies showing the decline in life expectancy at birth. So it's about 1.5 for the US. We did a study showing 1.3 for Brazil, with huge inequalities regionally and across race, ethnicity, and levels of education. So do you think that because of long COVID, we are going to take some time to go back to pre-pandemic trajectories of increasing life expectancy? So US is not a good example because they had stalled because of opioids and all of this. But Brazil was gaining about 0.5 years of life expectancy, so a couple months over every year in life expectancy, and many countries are having gains annually. So is it reasonable to think that this trajectory that we're seeing, this trend, is going to slow down a little bit because of many things, but one of those things associated to long COVID, which is still sort of the big question mark in the room in terms of severity, composition, and how long it's going to last?
Yeah, it's a very, very good question. And certainly the long COVID condition, as you said, we don't fully understand. It's an array of different conditions, be they neurologic, be they respiratory, cardiovascular. So there are different impacts on people, as you know. And those studies show, depending on how long people are followed for, and again, the follow-up periods are not standardized, so the percentages change. If you follow people for 6 or 8 weeks, you find up to 30% of people still have significant symptoms. If you follow people for 3 or 4 months, that drops maybe to 10 or 20%. And the range of symptomatology is very varied. It's generally mild, but there are people suffering severe long-term consequences. I think in Brazil, now you're approaching I think about 20 million cases probably in the next week. So that's a lot of the population. And that's underestimating the number of people who are being infected. And we really don't understand those long-term impacts. And, you know, we've seen going back to the polio, we still have polio survivors from polio in the 50s and 60s. And those polio survivors have suffered for a very long time. Their symptoms are, while rare, are very complex and require a huge health system investment to keep people healthy. So there's no question that long COVID is going to have an impact on the health system. It's going to be an extra demand on the health system. But as you said, there are other impacts, the loss in routine immunization, the slowness now in follow-up to cancer care. So the barriers to access to to immunization, to diagnostic services, to therapeutic services is also going to have it's a lag effect, but it's going to be there. The psychological distress, the increases in suicide. We really, this is a major shock to our system. It's also the socioeconomic distress is also going to have a long-term impact because, as we know, the economics of income are going to ultimately affect health. We know you know this, preaching to the converted, but 30 to 50% of our health is not actually dependent on health access. It's not dependent on health intervention. It's dependent on the social determinants, the underpinnings of work, of life, of how you're born, where you live, how you work, where you work, all of those different factors. So there's no question this is adding another stress, major stress to the system. And when we look at events, you said those numbers, 1.5 years, it seems like so little. But when you look back in the last century, there were only 2 or 3 events that did that. I think the pandemic of 1918 was the big mortality event. It shifted the life expectancy in the US and around the world. And I think Second World War did that as well. But very few events in the 20th century actually impacted negatively as a whole around the world on life expectancy. So this is huge. Already to have that sort of signal in the system is very worrying. And we've got a health system now that's on its knees, finding it hard to cope and recover. We're not through the pandemic yet, so we're not even, it'd be one thing if we were looking in the rearview mirror and thinking, how are we going to cope with the aftermath? But we're not in the aftermath. This fire is still burning. So we're dealing with the aftermath and the pandemic at the same time. And that's really hard to do in a system that's very exhausted. And I feel for our health workers across the board, from the primary care system all the way through. They've been heroes to us all, but they're exhausted now. The systems are exhausted. A lot of countries, through their revenue streams that support the health system, have been buying forward against future expenditure in the health system. So there's a lot of countries have been paying for the COVID response from money next year in the health system. And my fear is going to be the fiscal squeeze when countries come out of the pandemic and recognize that they've sort of sold the family jewels because they've paid forward all of the costs. And we're going to potentially see huge cuts in healthcare expenditure after the pandemic. At the very time you'd imagine we'd want to be increasing health expenditure, I'm afraid we may be decreasing it because of the way health is seen as an expenditure in most governments. It's not an investment. It's not a strategic investment. It's an expenditure. So I do have real concerns, but I think it can be avoided because that's the downside. I'm one of life's optimists. I think never before has the health of the health system become more relevant, or people are so aware now of how central health is and how central health protection is and how central the health system is to the well-being and security, economic security and health security of the population. And the question remains, what will people do, as you say, when they go back to those elections in the coming years? Are citizens going to stand up and demand that health and health systems and health access becomes a central pillar of our future? I think if they do, and if governments look to invest in health, then I think not only can we avoid the worst outcomes in terms of long-term health impacts, but we can take the next big step forward in health attainment. Because we're kind of stuck. You know, before the pandemic, we were stuck on the SDGs. We were stuck on many of the health gains. We were kind of doing all right, but we were treading water. We were not making it. We weren't going to make the SDGs, in my view, in health because we were stalling. And that stalling happened long before the pandemic. So the real question, I think, now for society as a whole is a really important discussion society needs to have with itself, and particularly society needs to have with politicians. Where is health in the priority setting in each country and around the world? And I think if we can have that conversation and understand that health is no longer an expense, it's no longer an expenditure. Health is an investment in the security of society. And if we make that decision, then I think we can not only avoid the worst of the outcomes, but we can actually build better health systems for the future. Now, that's the eternal optimist in me, but we have to be optimists and we have to believe that society, people, I believe in people. I don't believe in anything else. I believe in ghosts and I believe in people. And I think we're seeing an activation of society. And yes, we're seeing the misinformation and we're seeing people who, don't want to be vaccinated. We're seeing all of that. But overall, that's good because a debate has started. And you don't always get in a debate what you want to hear. You're going to have people for and against. You're going to have people who don't like what you say and people who do like what you say. What I'm happy for is that health is now being debated on the streets, in the parliaments, in the living rooms, in the bars, in wherever. And I hope that debate can turn into a new day for health systems.
Yeah, thanks so much for saying those words, Mike, because it's amazing to see in Brazil with our universal health system that it's something that was put together by the people. It didn't come from the government, came from the people, from society. And over its 30 years, it made so many advances in reducing inequalities, in improving health conditions. And now we see people that always criticize the system talking about SUS and thanking SUS and taking the vaccine, holding signs, thank SUS. And it's a shame that it needed a pandemic for the Brazilian population to really recognize the importance of a universal health system. But I'm glad, as you said, the health system is now in conversations. People see the importance of it. And I do hope that next year, people exercise the most important right that everybody has in a society, which is the right to vote, which in Brazil is also a duty, but it's the most important right we have to really voice their concerns and be able to, change the course of what we are seeing. And just a second thing is, thanks for saying you are an optimist. I always tell my students, if you're not an optimist, go to another field. Don't stay in public health, because if you're not an optimist in public health, you're never going to be able to do your job. So thanks for saying that. So I want to follow up what you said on the socioeconomic issues, and I'm going to invite Dr. Carlos Lula, who is coordinates the state health secretariats in Brazil, to ask a question. Carlos, please.
Muito bom dia a todos, muito bom dia a todas.
Good morning to all. First and foremost, I would like to thank the organizers for inviting me. We have two different approaches in this conversation. One from Maranhão, where I'm Secretary of State of Health, in the state of Maranhão, and then you also have to look at Brazil. And of course, there has been a very bad example, a very poor example on how to tackle the pandemic. Anyhow, this is, of course, a place that should be studied and understood. Maranhão is one of the poorest states in Brazil. Among the 27 states in Brazil, unfortunately, we rank last among the last when it comes to social economic ranking in Brazil. And of course, we're all aware that there are many issues to be tackled in Brazil, and Maranhão is the same. However, they are amplified, I should say. And when it comes to, of course, fighting the pandemic and debating the pandemic and the socio-economic consequences of the pandemic in Maranhão, would be, well, early on, we, of course, were full aware of the challenges that would lie ahead, that it would be more challenging than in the other states of Brazil. And just to give you an outlook, the government of Maranhão opposes openly and directly the federal government approach. The government authorities, the administration in Maranhão opposes the federal government. And therefore, we have had a different approach to the pandemic from the start. We actually knew of its severity, of the consequences. And today, in a certain way, we have good indicators. We have produced good indicators when it comes to the pandemic. We could have actually been doing very poorly, but no, actually, we have some of the best indicators in Brazil. If you look at the mortality rate, it's the lowest mortality rate in Brazil among the 27 states, 3 times lower almost than the mortality rate in other states. And our indicators are doing better than most countries in the European Union, actually. And therefore, this was actually a result of the approach of the Maranhão government from the start, because we were fully aware that it would be severe with severe consequences. And more than that, half of the workforce in the state of Maranhão is informal, half, 50%, meaning that this part of the population have to leave their homes to work every day, day after day, because they do not have working capital. They depend on whatever they sell day after day. And you have street vendors, beach vendors, and informal workers, artists. And these are the people that are most hardly affected by the pandemic, because they cannot work virtually, remotely. They can only work in the physical world. And they have to go to work every single day. If they work as bus drivers, and no one's using the public transport system, they will be out of a job. If there's no one out on the streets and there are street vendors, they won't be able to sell their products and therefore won't be able to eat. As Mr. Michael Ryan just mentioned, yes, we have been facing four key issues right now. Yes, you have a health problem, and as we all know, the health system is under pressure. There are patients who cannot have access to treatment because of the pandemic, more so in 2021 than 2020, because the pandemic hit us hardest in 2021, and there are surgeries that patients have not been able to undergo. Only 20% of the surgeries were performed, of those that should have been performed this year, because the hospital system was overburdened. And more, you have the health issue and a cultural issue, communication. You can't have two different approaches. If the health secretary tells people to mask up, but the Ministry of Health says otherwise, there's a problem. If the president of Brazil opposes what health secretaries are mandating or claiming, there's a problem. The president claimed that COVID-19 was a mere flu. And so there's a clash, there's a conflict in the messages that are spread. And that has been one of the key issues, because it didn't happen once or twice. It has happened oftentimes. People here in Maranhão saying, but the president won't mask up. Why should I do it? The president didn't get a shot. Why should I get a shot? Is it really safe? So you have this ambiguity, unclear messages from the president, and that is, of course, very negative. And therefore, it's a challenge when it comes to tackling the pandemic and to having one single discourse to the society, one unified source of information to our society. You have also mental issues and the mental health of first responders. There are many doctors, nurses, physical therapists that are on leave because they actually face terrible things, and they were also overburdened and burned out. And this is also having impacts in the society. Our mental health services, for instance, has waiting lines that, are unprecedented. Many people now with mental problems during the pandemic, and it's something that we will have to also address for a long period of time going forward, because of course we tackled the two key fears. Men fear two things mainly, madness and death. I think these are the two things we fear the most as humans, and as we can read in the literature. And these were the things we were mostly fearful of during the pandemic. We were afraid to lose our lives and to lose our minds. And yes, we've been under pressure for 16 months. And we know, we're fully aware that it'll be much longer than another 16 months to get out of the woods. And you have the health problem, the mental health problem, the social problem, and one more key issue in reaching the end of my intervention before I ask the questions to Mr. Ryan. We also have the social issues that we're facing. Of course, when it comes to education, students are studying remotely. Starting next week, we might go back to the physical classroom. Still, we have not measured the impact caused by the pandemic on students and on going back to school. We do not know what the dropout rate is yet, and what it'll take to have students go back to the classroom. We do not know what the social impact has been for students, for this generation that was away from school, from the classroom for almost 2 years now. So you have educational and social impacts there. And at the same time, we don't know what the consequences of the economic issues will be. Of course, there's unemployment, and we have the highest unemployment rate ever in Brazil. And we do not know, we have no idea how it's been worsened by the pandemic. By the end of this year, we will have a better idea of this scenario, of how it deepened over the last month. So, Professor, I would like to ask you, Mr. Ryan, 2 questions. What will we be facing going forward now with regards to the pandemic, with the new variants? And that has been, of course, driving the number of new cases and deaths. I would ask you to please give us an outlook of the next 6 months with increasing vaccination. Still, the pandemic is not fully controlled. And second question, what are the strategies governments could adopt or design considering the socio-economic challenges we will be facing going forward? Unemployment, children and adolescents that will not be going back to the classroom, especially in the poorest areas. And speaking particularly about the state of Maranhão. So which strategies could governments adopt to tackle the socio-economic challenges we will be faced with over the next months, and in attempting to go back to normal, certain normality, quote unquote? Thank you, sir.
Thank you, and very interesting listening to the experience in Marion, and congratulations on the work there, and for the lives saved with the comprehensive approach to disease control. Not always easy, and you did mention that specific issue of people who have to work, and day workers, vendors, informal workers, artists. It's been very, very tough on them. Because the social supports for people who work in that sector, across those sectors, just aren't there in many countries. And it's been a huge problem in so many different countries. You mentioned the social issues, the educational impact. I think that's something we're only coming to terms with now, in terms of the long-term educational impact. In terms of your specific questions going forward, I think there's a decoupling of the pandemic now. We have countries in which we have very high levels of vaccination, and we're starting to see that the death rates and hospitalization rates have fallen in those countries. But what we've also seen, and if you think about it, even in the last week, the United States has had over 500,000 cases reported. The United Kingdom, 250,000 cases in the last 7 days, 2 of the most highly vaccinated countries in the world. They're now back in the top 10, number 1 and number 4 on the top 10 list of countries reporting cases. The difference in that is that the numbers of hospitalizations and deaths remain very low. And this is happening in a lot of countries. So the Delta variant is continuing to spread. It clearly, and other variants are continuing to spread. Vaccines are not proving 100% effective against infection, but they are proving remarkably effective against severe disease, against hospitalization, and against death. So, if we're really, now experiencing, another increase in cases. We've seen, I think, the Americas in particular Central and South America, have probably been, for the longest period, affected. If you look at the number of cases and deaths every week for the last 6 months, the Americas has figured there. And even when you look at 5 out of the top 10 countries are in the Americas. 4 of the top, or 5 of the top 10 countries for deaths. 4 of the top 10 countries for cases are in the Americas. So the Americas has really suffered very, very badly. A prolonged impact on the health system. Huge stresses on the healthcare system for a very, very long time. And it is very hard to get out of that cycle unless we can increase vaccination. Because what we really need to do is end the emergency. We will not end the pandemic quickly. It's very clear the variants and the emergence of variants is making eliminating this virus very, very difficult. But we can eliminate the public health crisis, the social crisis, and the economic crisis if we can get more people vaccinated. Because I think, as you've probably experienced in Brazil, the difficulty is when the health system starts to fail. The health system comes under pressure, and then governments are left with little option but to shut down society. And you end up in this vicious cycle. Shut down society, take the pressure off the hospitals, then open up society, hospitals fill up again, shut down society. And most governments have had to deal with this vicious cycle. Vaccines will help to break that. But we also need to keep doing the other things. But the difficulty for you as policymakers is how do you continue to suppress transmission? And we can do that in terms of breaking chains of transmission without just continuing to disrupt the social, educational, and economic life of society. And that's a real challenge, especially in your situation where you have so many informal workers. So the question is, how can we support workers and people to reduce their risk of infection? Certainly, we have to avoid the massive crowding situations if we can. We need to continue wearing masks. We need to continue reducing individual risk of being exposed to the disease, while at the same time opening up critical infrastructure like schools. So how do we balance opening up certain parts of society with keeping risk management measures in place? And a lot of that is about investing in those communities themselves to try and reduce risk. And we've seen great examples from around the world, in Brazil, in India, and other places, where communities themselves have taken a lot of action with government support. You don't have to, it's my belief that you don't have to engage in massive lockdowns to keep some pressure on the virus while you increase vaccination rates. But none of this works unless we increase vaccination rates. And I think that's going to be the challenge. I know rates have increased in Brazil, but they're struggling all over the world. We deal with another huge inequity when we look at high-income countries versus low-income countries. You know, we're seeing 60, 70 times more likely to be vaccinated in a high-income country versus a low-income country. Right now, in the least developed countries, in low-income countries, we have maybe 1.3, 1.5 vaccines per 100 people. That's just not acceptable when you see the number in high-income countries is well over 60. So there's a huge inequity in vaccine distribution. But if we're going to get through this and get to some normality, we have to continue to try and suppress infections, but at the same time increase vaccination hugely. And that's a massive challenge in the current environment. The most important people to vaccinate are older populations with underlying conditions, frontline health workers. And there are still countries in the Americas and around the world in which even frontline health workers are not protected. And this is a tragedy. But identifying those older persons, those persons with underlying medical conditions. Remember, in this, the virus is not what's killing people in itself. What's killing people in general is massive inflammation in the lungs with a rapid reduction of oxygen. And in order for that reduction in mortality to happen, people need access to care. But most of the risk of developing those severe complications come with age and come with having underlying conditions. And ensuring that we vaccinate people with those conditions, people with hypertension, people with diabetes, people who are otherwise immunocompromised, and in vaccinating frontline health workers. If we can get to those high-risk people with good vaccine, vaccinate them the number of times they need to be vaccinated, once or twice, depending on the vaccine, then we will begin to severely limit the potential for this disease to overwhelm our health system and force you as policymakers to shut down your economies. So vaccine coverage in itself, for me, is meaningless. I would rather understand, for example, in Brazil, what proportion of high-risk people are vaccinated, what proportion of health workers are vaccinated, what proportion of people over the age of 60 or 65 are vaccinated. So I think we have to have some hope. Vaccines are doing a fantastic job. They're not stopping the virus, but they're stopping the death. And if we can invest more in vaccines, I think we can make progress. Over to you.
Thanks so much, Mike. This is and thanks for sharing those thoughts. So I'm mindful of time. So I would like to ask a final question, which is really a reflection. I don't expect an answer, but a reflection. So you just highlighted the differences across countries. So the so-called global south is really lagging behind on vaccination and lags behind in many other things. We know this. So do you think that we have any chance of starting a real coalition that brings the global north to support the global south and really move towards setting up a global epidemiological and genomic surveillance so we can really stop those things before, as soon as they emerge? We can identify new pathogens as soon as they emerge, regardless of where they emerge. That's going to need really the global north to think beyond their own belly buttons and help the global south. So do you see any chance of this moving forward? And can WHO play any role in pointing fingers at people and try to make this happen?
Yeah, well, I think the first thing we need to do is end this pandemic. And the only way we're going to do that is if we get better at distributing the vaccines we have. We're seeing an improvement. We're seeing more vaccines come into COVAX. We're seeing more donations come from countries. Now we have 12 plus countries donating vaccine. We need the manufacturers to prioritize COVAX so we can get vaccine to the developing world. We have the money to buy the vaccine. It's finding the manufacturers to sell that vaccine to us as a priority. And COVAX is a coalition of many institutions beyond WHO. So we need to get vaccine better distributed. But you're right, in the long run then, we need to readdress issues around global preparedness and global response. And my fear in this, and I think you're probably articulating that, is that we end up with this global solutions approach. So we had a global pandemic, so the solutions are global. So what we need to do is make more machines that go ping and build more laboratories and cut more yellow ribbons and do all of this super technology work, and then we'll fix the problem from satellite level. We will not fix the threat of emergency preparedness and response and health emergencies unless we go to communities. You know that in Brazil with dengue, with yellow fever, with other diseases, with cholera in the past. Epidemics begin and end in communities. That's the front line. That's what we've seen. It's frontline health workers, frontline communities. That's where it begins and that's where it should end. So if we're really truly to have a global system of protection, it's based on connecting communities to their national public health services and then connecting those national systems in an unbreakable global chain. But the global system should exist to support the local intervention, not the other way around. And this is where I hope, when you mentioned it before, we have the pandemic and we have the infodemic, and now we have the recommendation-demic, right? Where, I have telephone books. I mean, literally, I can hold my doors open with the emerging pontifications of various groups around the world who all seem to have the answers. They've all of a sudden, everyone has the answers. But I've been in here 30 years doing this. I've been through SARS, I've been through the Ebolas, I've been through the H1N1 pandemic, been through all of these diseases, been through the yellow fevers, the meningitis and everything. And in the end, what I've seen in the aftermath is people forget. We have a collective amnesia and we don't learn the lessons. We write the lessons and we make the recommendations, but we don't do anything about it. And I hope this time we won't do that, because I think planetary health, I think health justice and social justice and climate justice are linking together. I think people are beginning to see the existential risk we face in a globalized society with such unfairness, with such exploitation of people and our environments, that this is not sustainable. We cannot simply keep living like this. We have to find a better way. But the better way is not to build more technology. It'll be an important part of it, but we have to build from communities up. You talked about resilience. We talk about our most communities that are excluded from the economic and social life. We need to begin there. In the end, if the next pandemic, is more likely to be influenza than anything else, and it's more likely to emerge from an avian strain, What's going to matter is a local worker or farmer who keeps chickens in his backyard and has death in his chickens, that he knows who to tell and is willing to tell that person that he's sick and his animals are sick. And the local health authority knows what sample to take, and there's a lab to test the sample, and somebody's not going to come along and kill all his chickens and not compensate. Because that's the moment the next pandemic will begin. It will begin in a village, it will begin in a small community, and it will explode from there. And if we're going to avoid pandemics in the future, it's about understanding about lives, livelihoods, and understanding that moment, the spark, we need to find the sparks, not the fires. And if we're going to do that, we're only going to find them in communities and by working with communities. And I know for a lot of the people who think in global terms, it's not very easy. I've been using I watched a documentary a number of weeks ago about the building of the Golden Gate Bridge in San Francisco. And I hadn't realized, I should have realized in my life, that you have to build a suspension bridge from both sides and you meet in the middle. You can't build a suspension bridge starting on one side and go to the other. So you have to start on both sides. So I think we need a local to global approach where we recognize that local systems are contributing to this global alert we have. This global watch, this global surveillance is built up of millions of local nodes. And the global system can't function without those local systems. And that global system must invest in building those local systems. And the two meet together. So I think if we have that approach, then we make progress. I hope so. But then again, I'm a life's optimist.
Mike, I think we couldn't end in a better way, because what you just said stresses the importance of the community health agents. Those are the ones every day, door to door. It involves trust that you mentioned right in the beginning. They are the ones building trust, bringing information, and making sure that if that chicken dies, people are not going to hide the chicken, but tell the community health agent that the chicken died and we can avoid a next pandemic. So thank you so much. Thank you for spending an hour of your precious time with us. And thanks for all the work that you do, Mike. We couldn't be in better hands. We are all inspired by your words. And I hope that the next generation of leaders, the students watching us, they are inspired by your optimism, that they remember they have to go to the community. They need to listen to people. They need to listen to the problems, because we don't have the answers. No matter how big shot you are, we don't have the answers. We have to learn the answers by talking to people in the community. So, Mike, I'm inspired for, a month. Just listen to you. Thank you so much for sharing this time with us, and keep up the good work, Mike. Appreciate it.
Thank you. And thank you for all your work. And I'm sure you'll be with Jarbas. I heard Jarbas's name later. So he's a remarkable product of Brazil. And I'm sure he will also give you the PAHO perspective and other things. Jarvis is a good friend. So I'm glad he'll be with you later too.
Yes. Thanks, Mike. Appreciate it. Claudio, next to you.
Bom dia a todos, a todas. Saúdo inicialmente.
Good morning, everybody. On behalf of the authorities that we have on this call, our Dean, Pan Ongopian. Greetings to the other authorities that are with us, Mike Ryan, the director, one of the directors of WHO, and Carlos Lula, our Secretary in the State of Maranhão, who has shown to us the possibilities of working differently in the midst of the pandemic. And that's what we're going to talk about now. We're going to talk about the response of different governments to this pandemic. Talking about epidemiology and the consequences of the disease, one of the things that have been discussed is the official response. And because we can't talk about a response to the pandemic without mentioning specifically the role of the state in healthcare and social policy. There's no control that we have seen of a pandemic without the involvement of the state playing its roles. And in Brazil, I mean, we have had a sad observatory of what happens when the state is absent or sometimes when the state opposes to the response. So we're going to have a round table with guests from different governments. We're going to have Winnie Weeping talk about the Chinese experience, Sachi Balsari with the Indian experience, Stu Goldstein from South Africa, and Patty Garcia from Peru. So we're going to open this discussion with the presentation by Winnie Weep, who's a professor of global health, healthcare policies of the Harvard School of Public Health, and also director of in the Department of Global Health and Population at Harvard T.H. Chan School of Public Health, and also director of the China Health Partnership at Harvard University. She was People's Professor of Health Policy and Economics at Blavatnik School of Government, University of Oxford, and Senior Research Fellow at Green Templeton College. So the floor over to our guest, and thank you very much for participating with us.
Thank you very much for inviting me to share the experience of the Chinese government's response to COVID. If my voice starts breaking up, do just shout and let me know, and I will try to slow down. So first of all, I want to say that I don't represent the Chinese government or the Chinese government's view, but I'm just reporting to you from what I understand and have analyzed the Chinese government's response to COVID. And I will try to extract the key lessons and leave the details and nuance during the discussion. I'd like to separate China's response to COVID into two separate periods. The period which earlier I would say what Mike Ryan and Marcia have referred as the crisis period versus the post-crisis period. In fact, I think the one lesson that one can learn from China is try to put that crisis out of the crisis period as soon as possible, so you can have the bandwidth to deal with the complex situation that still follows. So the crisis period will be approximately December 2019 to around March or April 2020. And that's during the major outbreak in Wuhan that most of you know about it already. I mean, the first strategy that all of us know about is, of course, the lockdown of Wuhan. And I think it's still debatable whether China needs to go to that extreme approach. My reflection is that probably by the time the cases were surging in Wuhan, China probably doesn't have much other strategy than to lock down, because it happened at the time of Chinese New Year when everybody is traveling. You just cannot stop people from traveling. So the way to lock down is not just lockdown, in my view, is not just localizing that outbreak, but in retrospect, I also think it was a wise strategy is when China was able to localize the outbreak in Wuhan and even in the province of Hubei, what it was able to do is then to mobilize the resources from the rest of the country to go to Wuhan to help them. And by resources, it is a combination of personnel, equipment. I understand that during that 3 months, over 400,000 of people has been mobilized, health workers from different provinces, and they go in phases, in teams. The second strategy that China used during that time was using the shelter hospitals for isolation and quarantine. In the beginning, actually, China just asked its people to stay at home. And what happened is that the data analysis at the very beginning realized that a lot of the people got infected was because they just flocked to the hospitals. So they got infected in the hospital and they get infected at home. So what China immediately do is that build these shelter hospitals. And I mean, again, this is not new strategy. Going back to history, it has been used in other pandemic. But I think China did go back to what we have learned in history on what might be helpful and immediately put into action. So they turned these stadiums, huge stadiums, into shelter hospitals, and they were able to do it in just 2-3 days' time. And what is the advantage of doing these shelter hospitals is that everybody who are suspects, everybody who has been identified through contact tracing, instead of making them stay at home, stay in the community where you cannot control what is their living condition, as some of the living condition are actually quite poor, quite crowded, it was put into these stadiums. So these stadiums serve several functions. They basically are isolation and quarantine quarters for those who are suspects. But then during the period of observation, for those of people who actually do develop COVID, they were immediately transferred to the hospitals. So it's also playing a role of triage. And finally, in these stadiums, they were also provided sort of daily activities of which people feel that they are actually not isolated. So at the end, when the government, about April last year, when the government was trying to reflect on what were the strategies that went correct and awarded the people who recommended the different strategies, lockdown and shelter hospitals were the two that were prominent. The third strategies that I would like to highlight, and I'm really glad to have listened to the conversation between Mike Ryan and Marcia, was precisely mobilizing the community. This is the one thing that is not mentioned enough in the global discussion about China's strategy. Everybody talks about a lockdown. Everybody talks about these big shelter hospitals. By the way, I also want to mention that China also built 2 huge hospitals for acute care quickly, but they were not actually having much effect at the end. They realized what is effective is really cutting the infection upstream, not waiting for people to get infected and then put them into the hospital. And by community, to use the words that were just used in the last hour, who are the community agents? One group of agents are actually the Center for Disease Control's local agents. Unlike the United States, the Center for Disease Control in China is penetrates all the way from national, provincial, city, and all the way down to community and village. So you can mobilize them. They are there. Second are primary healthcare providers, but I would say that actually China's primary healthcare system is not as good as Brazil's system. The third group of community agents are traditionally, China do have what we call neighborhood communities. These neighborhood committees basically know about everybody quite well. And they are very effective, this group of people. What do? They go around and do public health education. They are the people, as the conversation just said, they are the people that the residents trust. So this is the group of people who go around and tell people they need to wear masks, they need to wash their hands, they need to have physical distancing, and they're responsible for making sure every household has enough masks. They are responsible for contact tracing. They are responsible for mobilizing people to go do tests. How did China get people to do tests? Yes, they have tests available, but it is the local community that get people to go and do the tests. And just having the test alone is not enough. And what is also amazing is that they actually provide daily support. What does it mean? If an old person needs to be driven to a hospital for tests, they've organized to drive them. The taxi driver who is not working at that time do that job. They mobilize and organize themselves to buy groceries, to deliver food. And that makes shelter at home much more practical and feasible and acceptable to people than to have just a government policy saying that you need to stay at home when you do not provide all these help. And finally, I have to say that scientists do an important role. You realize that if you review that period of time, many of the major announcements is actually not made by the government. It's actually made by the CDC director. It's actually made by the scientists who come out and give people the advice. So post-outbreak, and that is starting from about last year's April or so, what is China's strategy? China's strategies has always been early case finding, early contact tracing and isolation, early identification of the origin of any new confirmed cases. And in fact, I think that target is a bit tough. They still want to target as zero local infection. So right now, a lot of the infection that confirmed cases that we are hearing in China are imported cases. But for them to be able to trace the origin and therefore from that origin, trace anyone who had been in close contact has been a priority strategy. In other words, and if you find them, isolate them, quarantine them. So, I mean, even my colleagues, my friends in China, they seem to be spending all their time figuring out each local city's rule on quarantining. It sounds very inconvenient, but this is how they were trying to control the any further outbreak. So what China does now is they classify the entire country into locations of high, medium, and low risk based on outbreak number. Then they use digital technology to track everybody's travel pattern. And so everybody would have a code that identify whether they have been to places that is red, which is high risk, medium, which is yellow, which is medium risk, or low risk. And if you travel from any place that is high or medium risk to the destination city, this is all within China, you will be required to satisfy. And whenever there is new outbreak, China would impose population-based testing. In other words, they would try to make sure that no one falls through the crack in making sure that they're not going around, going to the community, infecting other people. The second major strategy is, of course, massive vaccination. But I would say that massive vaccination only appeared recently. For many years, for many months, China did not pay attention to vaccination. And in fact, the vaccination strategy is a little bit different from the US. In fact, they don't vaccinate old people. The argument is that since the infection rate is low, the priority is to vaccinate people who are actually going out and have a lot of activities and potential contact with risk and infection. It is only until recently that they're trying to reach the bulk of the population. I'm going to leave the effectiveness, efficacy of the Chinese vaccine as a separate discussion, a point, but we can do that during the discussion. The last strategies that they do is to have very strict international travel restriction, and practically the international border is closed at this moment. Unless you're willing to go to China to have a minimum of 14 days of quarantine in a hotel, plus another week or maybe another link to pay these time prices, fine. I do want to cover a little bit about under these stringent strategies, what happened to non-COVID care? Non-COVID care during the first few months practically was brought to a halt. All the hospitals in the whole country practically has closed elective care, practically has no outpatient services, because all of them is really repurposed to identify and treat COVID cases or being sent to Wuhan or Hubei province to help them. It is during this period of time that care is to a certain level being maintained by care delivered over the internet platform. Now, care delivered over the internet platform actually existed before COVID, but they were not very popular. What happened during this period of time, most of these services that are provided by private industry, they actually offer these care for free. They attracted a lot of physicians to sign on to their platform and provide free care. And when the government saw that, the government stepped in immediately to get the universal social insurance scheme to actually pay for these care, and also streamline the review and approval process. So I know that I have used almost my time, so let me do a quick summary. I think China's strategy in retrospect is end the crisis phase fast. What they have done is very, very drastic, and some would say draconian, and people are still debating about the cost. But the fact that it is able to end the crisis fast allowed them to buy time and to really smooth out the resource need in order to go into the second phase, which is the current phase of maintaining and prevention. The second lesson is that despite China is a big country, a lot of the decision is actually centralized and coordinated at the central level. There is, in a way, a commander-in-chief. And in fact, if you read the document around that time, the narrative that they use to fight against COVID is a war, it's a battle. It's a battle that's led by some commander-in-chief, and they use it to rally the population to feel that they should be following the government's advice in order to fight this battle. And so centralizing the decision-making, but localizing the outbreak, which is very much different from the United States. If you look at the United States, it's almost like every time you put out a fire here, another fire would start there. And so the way China does it is localize this fire, put that off, and then move from there. The priority given to early detection and isolation, I do think it is something very, very effective, and it's low cost. And if you organize it enough, especially using the community to help with that, it is feasible. So again, I want to re-highlight the important role played by the community. I think China also quite smartly used technology, digital technology, to do contact tracing. There are issues about privacy and all that which should be discussed, but we should not ignore that this has been quite effective for quick decision. And finally, I have to say good governance is essential. And let me just show you this graph. After SARS, China prided itself by building a state-of-the-art information system, of which any infectious disease that happened in a national hospital, provincial hospital, all the way down to the community will be reported in real time through an internet to go to all the different levels of Centers of Disease Control, and then directly going to the Health Ministry and Health Bureau, and also directly going to the government. It broke down during the early period of Wuhan because what China had was an information system. However, who get to use what information and can make what decision was completely fragmented and unclear. So I want to emphasize that because I hear so much about the importance of information system, and I would have to emphasize this is a failure lesson from China. If you build the best management information system without a clear governance system over it, you still would not achieve what you want to achieve. So thank you very much for allowing me to share some of my observations of China's lessons, and I look forward to learning from other countries and also for the conversation afterwards. Thank you.
Muito obrigado, professora Winnie.
Thank you very much, Professor, for your presentation. I would like to point out at this moment, well, if I may, that as mentioned earlier by Professor Yip, it's extremely important to engage the community. And this is without a doubt a key point when it comes to how China responded, and mobilizing the community is not a spontaneous action. In Brazil, we also had the mobilization or engagement of the community in different respects. However, it was produced, it should be produced with reliable information, and of course, by sharing information flows that are science-based and reliable. And you have to, of course, build awareness continuously and educating the population if you are to control the pandemic, to fight the pandemic, which is also very different. It differs drastically from the Brazilian scenario. And now I would like to give the floor immediately to Professor Balshari, the emergency responder in Harvard Business School and Medical Center since 2009, affiliated to also the Health Emergency Center, Harvard University. His research has contributed to advocating for the rights of vulnerable populations affected by disasters and humanitarian crisis. He is the head of the Young Digital Health Network in Lakshmi Mittal Asian Institute, a research group and their products have also shaped the digital health system in India. Co-director of Crisis Ready IO, an interdisciplinary research network, and that is also of Harvard, and direct relief for lawmakers that respond to emergency disasters. Professor Sachi, the floor is yours, please.
Thank you very much. Am I audible?
Yeah.
Great. All right. Thank you kindly for inviting me to this very important discussion. I'm going to build off right where the last two speakers, Dr. Ryan and Professor Yip, left off, and the common themes we've identified. You know, as we think about the responses around the world, it is striking, I'm sure to all of us, as to how simple and yet extremely complex the response to the pandemic was, right? Sort of putting on my clinical hat, just what exactly are we dealing with? By March or April last year, right, 2020, the world already knew, thanks to social media essentially, and very early reports from China, and then from Italy, and especially sort of the WhatsApp videos from the emergency rooms in Europe that went viral, that the majority of people that will get exposed may or may not have COVID, depending on what kind of exposure. Most people won't develop COVID. Of those that will get COVID, the vast majority will be asymptomatic. Of those that develop symptoms, most people will have mild symptoms, and we've heard this recurrent theme over and over again. And there is a small number of people that will get short of breath. And of the people that get short of breath, most people will only need oxygen, maybe pronation. And a few months later, we realized that the correct dose of steroids for a short amount of time may help. It is only an extremely tiny slice of the population that gets exposed and gets COVID and is symptomatic that will need critical care. The vast majority of the world does not have the capacity to take care of these people that are critically ill. And that capacity cannot be built overnight. No matter how big a hospital we build or how many ICUs we put up overnight, the clinical capacity to take care of these patients doesn't exist. So as Mike pointed out, what we really needed to do is to quickly identify those people that would need oxygen, the mild to moderate cases who could be turned around before they got critical. That needed to be the clinical thrust of all we did for COVID-19. In India, as many of us will recollect, there was a major lockdown announced at the end of March. This is 1/6 of humanity being told that they will be under lockdown, given 4 hours notice, all right? Cases had started coming into India. There were about 1,000 cases that were detected when that decision was taken, mostly in urban India, as you can imagine, as you know, the virus would have arrived on flights into the urban centers. So normally the streets of India that look like this, right? This is Connaught Place in New Delhi, not too far from the parliament, was emptied out, completely emptied out, right? You're talking of one of the most populous nations in the world, very successfully staying at home. But there was this other India, the tens of millions of migrants that come to the cities to often earn daily wages. Many of them live in very close shelters, right? Share rooms. Their families are back in the villages in India. And many of them would sleep in the streets. And when the lockdown was announced, there was unfortunately not really a plan for these tens of millions of migrants. And so they flocked, thronged in high density, as we can see, to public transport systems, trying to get back home. The public transport system was also shut down, and so they decided to walk the tens or sometimes hundreds of kilometers it would take to walk home. As you can imagine, that there were several challenges with this kind of draconian lockdown, of course. Even urban middle-class India wasn't prepared, right? So those with the means were suddenly asked to stay at home, and essential services were open, but it was entirely unclear how folks were supposed to navigate these services. The elderly were locked in at home. As you can imagine, the middle class in India is highly dependent on domestic help that comes home. And without that help, you suddenly took people that even had the means and made them very vulnerable. This was a tiny part of the population. The vast majority of the population that does not usually have means essentially were on the streets trying to figure out what happened and where they could get not food, but wages, because they were dependent on daily wages for survival, money that needed to be sent back home. India has one of the largest midday meal programs in the world, which came to a grinding halt overnight. So now we have tens of millions of children who are dependent on this food, sometimes their only substantial meal. When they go to school, being denied that meal. The impact on education, of course, will have long-term consequences, and it's too early to see what that is around the world, as all our students have missed class, right? From Harvard to the primary care center in the rural global south. But telemedicine or teleeducation was not a solution for the vast majority of these kids. What the early response was marked by was also questionable science. You saw sort of these large hospitals in Professor Yip's presentation as well, where the Indian government's response initially was to centralize the response. So they activated the Disaster Management Act. They took full responsibility, saying, look, this is a national emergency. The state needs to be involved. This is not just any public health problem that can be locally solved. And part of that draconian response and responsibility was to say, we are going to identify, contact trace every new case. And as soon as a household is suspected to have COVID-19, the household will be sealed. People will be taken out and supported in these isolation care centers. While that is laudable for isolation, in hindsight, and not a year later, but I think around the summer of 2020, many scientists began to question the wisdom of this isolation. If you're living in a dense household and one member has symptoms, it is highly unlikely that everyone else has not already gotten infected. There was no treatment to offer in COVID. I think the signaling that governments did was somehow that one took, if one was taken to these isolation centers, that you were safe. But if you think about the first slide, there was nothing to do. There is to date, 18 months into the pandemic, very little we can do about COVID-19. Most people need supported management at home with a little paracetamol. Only those that will have increasing oxygen requirements need to be quickly identified and be provided oxygen. There is no oxygen at this isolation center. There is no oxygen at most isolation centers around the world. And so the question is, to what avail are these centers being built if what it does is actually terrorize families? What this ends up doing is people are afraid to report their symptoms because no one, rich or poor, wants to leave their home. And this is different in different country contexts, of course, right? So as Professor Yip said, in China, this might have been socially acceptable and people may feel comfortable at these centers. In India, not so, because you have the juxtaposition of various socioeconomic strata living very close together. And most people were too afraid, if they could, to report their symptoms. The way this backfires is then by the time you actually report your symptoms, you are so sick that you'll end up in the hospital critically ill. India also has a mixed medical response system. There is Ayurveda, there is homeopathy, all formally recognized by the state, and there are medical schools for various disciplines of medicine. Various state governments in India, health is a state subject in India, were actually sponsoring the mass distribution of these concoctions that have no evidence base. Right? And what that does is two things. One is perpetuates the false notion that, oh, it's not really harmful. It could be anything, and we will see how the allopaths follow it as well. And so if it's not really harmful, it's okay to give it. And the other is a false sense of security. I'm drinking this potion every morning, I'm protected. India's contact tracing app was downloaded by 100 million people in weeks. It was the fastest downloaded app in the history of apps. For contact tracing, digital contact tracing to work, you need about 60 to 70% of the population to be participating actively in the contact tracing app. 60 to 70% of the population does not even own smartphones, much less smartphones that are BLE enabled. So regardless of whether the Bluetooth technology and the way the analog world of sort of 6 feet and 15 minutes of exposure was translated to the digital world of contact tracing apps, regardless of that, the arithmetic doesn't work. However, these data and testing data were used to create these hotspots, as they have been around the world, because that was sort of the wisdom of the moment. But what these hotspots do is affect individual and group freedoms, right? You are asked to stay at home or not leave your home or travel or not travel based on data that are questionable, data from the contact tracing app and data from testing. In April 2020, at one of the Harvard hospitals that I work at, when we initially started testing, there were no tests. We all remember tests had to be made because COVID was novel. So there were very few tests, and we had set up triage tents across these hospitals. As people started coming in, they were being tested. Then the wealthiest nation in the world, the United States, ran out of Q-tips. Essentially, we had no nasopharyngeal swabs to do the testing. So we stopped testing and we said, reserve the tests only for those that are very sick. If people come with symptoms in a pandemic, tell them they have the disease, go home, only test the very sick. Then tests were available and we started expanding testing. Then rapid tests were available and Harvard University bought these tests for everyone who was on campus and you were testing daily. What the epidemiologists and demographers here would be horrified by listening to this is what happens to the denominator. Every time you test, every time you change the testing criteria, the denominator shifts. And yet, barely was there a country in the world that was reporting what those tests represented. And yet these tests were made to color these maps that determined what the public health response to these districts should be. Anyone who could code was making SEIR models. I'm sure Professor Castro wanted to tear her hair out when the next new model arrived at her desk on a Monday morning. In India, the models were predicting that the epidemic would be over by October 2020. And the problem with this is that the scientists were not at the decision-making table. Around the world, including in Massachusetts, you had consulting companies sitting with governors' boards. The biggest names in consultancy were telling the governments what triage criteria should be, what the model should look like, and what the responses should be, and often apropos of nothing. As Mike pointed out, when we look at aggregates in countries, we miss the nuances of actually what is happening at the individual level. India is a large country, it has 1/6 of the world's population. There is wide variation from city to city, village to village, in what state capacity looks like. In the state of Kerala, the abandoned isolations, that home isolation, and provided, as was seen in the Chinese response, the necessary care to keep people at home. Can we help them with transport? Can we help them with food? Can we bring medicines to them? And society sort of also rises to the occasion. My parents were elderly. They were in lockdown in India in their mid-70s to late 70s. And the neighbors ensured that they did not leave home, right? Society, the community spirit that exists in these societies and cultures, which is very different from urban United States, allowed this kind of home isolation to be possible. My parents did not leave their home for 3 months, because neighbors brought groceries, neighbors brought medicines to them at home, and they managed to sort of ride the first wave of COVID without even risking being infected. And I think we need to remember how we tap into what society can do. Keeping an eye on time, I'm going to just quickly mention the vaccine response in India was very unfortunate. While India had one of the largest vaccine manufacturer at home in India, largest vaccine manufacturers in the world, in India, India did not actually invest in purchasing and guaranteeing these vaccines till January 2021. And so our vaccine rates fell low. There was, of course, Indian exceptionalism, as there has been American exceptionalism and sort of disbelief in science. One of the world's largest religious mass gathering was allowed and sanctioned by the state in early 2021, and election rallies were held throughout the country. It was kind of inadvertent that you would then see this massive second wave. The second wave, as all of you know, and I'm not going to harp on this, has been marked by excess mortality. We have seen these visuals of funeral pyres around India. It was also marked by this desperation in India by the billionaires, by the technology companies, by the corporations and the Indian diaspora to do something. And the something, because the visuals show people gasping for oxygen, has been to donate lots of oxygen concentrators to India and to build ICU beds overnight. Except oxygen cannot be in isolation of the entire continuum of care. The national guidelines continue to peddle ivermectin, hydroxychloroquine, CT scans, remdesivir, and inappropriate uses of steroids for months and months and months into the pandemic, leading to one of the largest outbreaks of mucormycosis or black fungus anywhere in the world. We still don't know what this may have caused. Hypothesis is that it might be the zinc prescriptions, because patients with COVID would get vitamin C, zinc, dexamethasone, whole slew of antibiotics, and remdesivir. What we were panicking about, and I will end with this, is what all of this would do to rural India. The third wave photographs and videos and stories that we have heard are from urban India. The latest estimates from a couple of days ago is that there might have been 4 to 5 million excess deaths because of the COVID pandemic. It was limited state capacity on top of weak underlying health system and a deep politicization of science that we have seen around the world. As the pandemic spread to rural India, civil society and scientists banded together. And they said, we cannot depend only on the state response, let us augment the state response. A wonderful study done by Professor Mushfiq Mubarak at Yale University, a randomized control trial of over 350,000 people, determined how do you actually normalize mask wearing. It's one thing to ask people to wear masks. It's another thing to get people to wear masks that cover their nose and their mouth and decrease the transmission rate in the community. And what does it take to actually do that? Clubbed with that, several of us said, look, all we need to do is identify that small slice of people that need oxygen, make sure they get oxygen at the right time. Can we break this down? Can we protocolize this? Can we make this a checklist for the manager, for the healthcare worker, for the patient, translate into multiple languages, and work with a slew of community organizations across South Asia, across India, Nepal, Bangladesh, to say, can we take science to the people? Can these countries, with political differences, but with a shared society, speak the common language of science? So community-based organizations that together serve hundreds of millions of people across this region basically took the latest scientific protocols vetted by scientists from around the world and converted them into these very usable metrics. Very usable implementation steps for community health workers to go door to door, support people to do home isolation, and quickly identify those that needed oxygen, take them to oxygen centers, not isolation centers, centers where you were actually given oxygen, but heavily protocolized, so that you could decrease the demand on the ICUs. Here's what vaccination in India looks like. We're still far behind. Absolute numbers are very impressive, of course. 435 million doses have been given. India, unfortunately, is a very large country, and we have a long time to go. So until then, I think what India falls back upon is now the people of India who have to fall back on basic, one-on-one principles of public health, masking, isolation, and the correct kind of treatment when possible. Thank you kindly for inviting me.
Thank you very much, Professor Sachit. We see in many aspects there are similarities between India and Brazil, especially when we look at the lack of political leadership, telling people what to do in relation to isolation and the lockdowns politics, and also when we regard to the scientific knowledge as a basis of the response. I think, there's no other example like Brazil that denied science so much, but we see also in India, this has been a problem with a good example with the medicines recommended for treating the disease. Well, we go to our next presentation from the experience of South Africa, Susan Goldstein. I'll read it in Portuguese. Susan Goldstein é especialista em medicina e saúde pública, diretora do
Is an expert in public health medicine and department director of the SAMRC Center for Health, Economics, and Decision Science. She has a special interest in 30 years of experience in communication for social change, health promotion, socioeconomic determinants, and health in children. So over to you.
Okay, thank you very much. First of all, a couple of disclaimers, and thank you for inviting me. I'm really honored to be amongst such esteemed presenters. Listening to Mike Ryan, I really am glad I'm not in your booth, sir. I am not representing government, and this is a personal view of what the government response in South Africa was. And I'm speaking as a health promotion academic. So this is the other day in South Africa, we had what some people called economic insurrection. People looted, and there was a lot of rioting happening in the streets of two of our provinces. Context, South Africa, just for people who are not aware, we were colonized. We're right on the southern tip of Africa. first colonized by the Dutch, then by the British. They managed to keep their power by land grabs and, of course, brought slavery to the country. This was followed by apartheid in 1961, which became famous for institutionalized racism and keeping Black people basically away from the wealth of the country and separating people physically and through education, through lack of services and so on. And of course, this has resulted in huge inequities. So even since our liberation in 1994, you can see on the left-hand side are the informal dwellings where people live, hundreds of people living on top of each other. And on the right, the middle class with reasonable, nice housing. This inequity, of course, is in the health sector. So at the top, you see a hospital with a helicopter, absolutely up to state-of-the-art services. And at the bottom, you see what the vast majority of people have is overcrowded clinics, mainly for women and children, but for everybody. Health expenditure, most of the money is spent on only on 16% of the population. The quality, as you can see, I mean, when you're overcrowded like that and you don't have resources, the quality deteriorates. So the population is 58 million. We've got huge inequality, as I've said. So this epidemic jumped in on a really struggling health system. We have 31% of people have AIDS, 36 NCDs, injuries. We have perinatal and nutritional problems, as well as infectious and other parasitic diseases. And even our maternal mortality rate is very high compared to other countries. So if you even look at India, Russia, Brazil, we're almost the same as India. And in fact, ours rose after 2005 due to the AIDS epidemic. 55% of South Africans live in absolute poverty. And then there's the other context. We've had 10 years of looting of the state by a whole cohort. People blame President Zuma, but he was just one of looters at all levels of the state. So here's the COVID timeline. And if you start at the left, on the 5th of March, we had the first case in South Africa. And we had a state of disaster declared on the 15th of March. And then we had total level 5 lockdown on the 26th of March. So that was, if you look at the numbers of cases, it was before we had many cases at all. So our government was really commended to start really trying to do something early on. And then they developed a 5-level system where they would have level 5 and then it went down to level 4 on the 9th of May when people could no longer tolerate it. And you see it's not really related at all to the numbers of cases. And then you look at level 3, level 2, level 1. And then we went back up to level 3 for our second wave. And we went to level 3 in our third wave. And in fact, we went up to level 4 recently and are now back down to level 3. So all these are very confusing and disturbing. But I think the point that the previous speaker made about who's being tested is absolutely critical when we look at these numbers, because there are so many people who are just not tested and we just don't know the denominators. You'll notice at the bottom that in our level 4s and in some what they call adjusted level 3, alcohol was banned completely for sale or distribution. And the idea behind this was to free up emergency wards particularly, and to give space in the hospitals for COVID cases rather than for trauma and violence, which is where a lot of cases, especially on weekends, came from. And it did really help. The stats have been shown that trauma cases drastically decreased during the alcohol ban. However, there was, of course, huge backlash by the alcohol industry and a start of some bootlegging and illicit trade. So, yeah, that was something that was an interesting, different thing that South Africa did. So the good. What was the good of South Africa? Sorry, can you hear me? Okay, I'll carry on. The good was that there was a very rapid response to the pandemic. And the second point I think is really critical. There was a whole of government response. Usually when it comes to some sort of some illness, and certainly with HIV and AIDS, it took years and years and years before there would be a whole government response. There was a massive mobilization of business. There was a solidarity fund, which was lots of people contributed to try and support small businesses, to try and support destitute people. They had the lockdowns, and I mentioned the alcohol bans before to free up the health services. There was a mobilization of health services to prepare. So they were scaling up of testing, trying to get the health services prepared for the coming wave of infections. And so I think that was something that was relatively successful. And they recognized that people could not just stop working without some form of social assistance. So I think that was important. And then I think the other thing that South Africa was lucky at, as compared to perhaps the rest of the continent, is that we have a very good scientific community, and we had a lot of excellence in monitoring the epidemic and the sequencing of the virus. Didn't, however, help when the government didn't listen to the scientists, of course. What's happening? The not so good part was the vaccines. We had a very slow rollout. Only began rolling out our vaccines in March. Also, there was an issue of only no weekend vaccination, so that stopped the rollout. We had two very unfortunate events. The one was that we had bought the AstraZeneca vaccine, and then it was found to not be effective against the beta variant, which was very disturbing. So the government actually gave away all our AstraZeneca vaccines. Then we had the problem with J&J in the States, where the factory was closed, and all the J&J that we had bought couldn't arrive. So we had a really terrible delay in the rollout of vaccines. And in fact, our initial rollout, I think until April, beginning of May, was a study that was done using J&J vaccines run by our Medical Research Council. So that was only for health workers. So we're really far behind, slowly creeping up. I think the numbers, again, 6 million vaccines, but it comes to about 6% of the population. What was good is that vaccine acceptance is rising from studies that we've had. In February 21, it was 71%, and then in May it was 76%. South Africans are not particularly vaccine hesitant. They really aren't getting the vaccines yet. So that's the not so good. The bad. So the bad, and people have emphasized this before, but I think for me, what's important is that there was a lack of public participation. And although the government tried to bring together groups, so they had an advisory group, they had a national committee of all the ministers, the government ministers. And then after a couple of months, about 3 or 4 months, they decided to have what they called a behavior change advisory committee. But I think the problem was that they didn't consult ordinary people, and they didn't listen to ordinary people. So I'll come back to what the consequence of that was. Our second point was the lack of transparency. So nobody knew what was going on. Poor communication. We found out many months later that part of the poor communication was a tender that had gone to somebody's relatives and had made money out of it. The lockdown regulations sometimes had no logic. So people started getting tired of them. For example, one of the things that when you went into a shop, you were not allowed to buy summer clothes. It was winter, so you were allowed to buy winter clothes. But if you wanted to buy summer clothes, you were not allowed to. You were not allowed to buy tobacco. And a lot of people argued that tobacco had very little bearing on COVID-19 infection or severity of illness. So that was a huge debate, and people got quite angry about it. The other thing was that they brought in the army to try and help keep the lockdown, because as you realize, people were very poor, living in miserable situations, cannot possibly adhere to lockdown. It's impossible for a family of 4 to live in one room for any length of time. But the big thing was the disruption of the food systems. It created a massive increase in hunger. And there was a lot of relief, a lot of community people came together. They really collected money, made food parcels, but there was terribly poor coordination of this relief, and it often didn't get to people who needed it. And I think you'll see, I don't know if you can see this clearly, but this is a 2-kilometer line of people to get food parcels in the height of the epidemic. So first of all, it's getting people all crowded together. But second of all, can you imagine the hunger if you have to stand in a line for 24 hours probably? I think just to carry on with the hunger issue, because it was very, very serious, about approximately 10 million people and 3 million children were in households affected by hunger. And of course, hunger changed how somebody was talking earlier about mental health issues. I mean, in a family where children lived in households with hunger, 51% reported depressed mood. And then we get to the ugly. The ugly is really about corruption. And sadly, and I think to many of our horror, even during this terrible pandemic, people were lining their pockets. So there were all sorts of corruption around PPE equipment, around giving money to friends and families. We were supposed to have field hospitals. It breaks my heart to have heard how China built their hospitals in a week, and our field hospitals just never got built because it was fraudulent. It went into people's pockets. And our Minister of Health was actually suspended in the middle of this terrible epidemic because of what was seen as fraud around the communications, a group called Digital Vibes. So what are the lessons? For me, the big lessons were that communication for social change should be central to any strategy. And a big part of that is engaging with people, not only telling them about and educating them, but listening to them and understanding what the issues are. For an example around that I didn't mention earlier was the informal food traders. A huge amount of food is distributed in informal ways. And what happened was that these people were not seen as essential workers, and so they were locked off the streets and kept off the streets by the army. So not only they didn't have a means of earning a living, but also the people that they were feeding. And so people just could not get hold of food. This was a major problem. I think preparedness for any kind of pandemic, and I think this is something that our government needs to take terribly seriously. The reason why China could involve communities so well is because they were already organized. They already have networks of people that they can listen through to the populace and communicate with. Transparency, of course, we know, and as somebody else mentioned earlier, good governance. I think what's also important is understanding trade-offs and opportunity costs. These decisions that government has to make, and I think everybody has mentioned it, these are not easy decisions. How do you choose between staying home and starving or going out and getting COVID and possibly dying? These are hard choices for individuals, but they're just as hard for governments to make, you're really caught between a rock and a hard stone. So how do you make these choices? And one of the things that we suggest as a lesson is that if you hear as many other people's voices as possible to make the right decisions, because those trade-offs are going to be huge. And what we're suggesting, and what I would suggest, is that there needs to be some sort of priority setting body that helps with looking at advice from communities and affected people, so that all comes from the bottom up to the top, so that people can hear the advice that they're giving and try and make decisions in a positive way. And I will stop there. Thank you.
Thank you very much, Dr. Susan. I'll take a comment that our colleague Sachit brought to our chat, that how striking is the universality of these images all around. And that's true. When we see what we saw from India, from South Africa, in Brazil, we will not see the images here, but everybody in Brazil who's participating is very familiar with that. It's really amazing how the similar lack of response, the lack of government planning, it brings highlight to the dimension of our preparedness and how much our preparedness for epidemics is only focused on the health services and healthcare system, and there's no preparedness of the government in general. So we see hunger, we see a lack of communication, lack of transparency, corruption, everything that we know will happen every day shows up and now almost blasts us, and when we live in a crisis like this. Well, we go now to the presentation of Patricia Janet Garcia Funegra from Peru. Patrícia é professora da Escola de Saúde Pública da Universidade Peruana Caetano.
Patrícia is professor of University Caetano Heredia of Public Health, former Minister of Health in Peru, Dean of the Public Health School in PCH, and former head of the National Institute of Health in Peru. She is acknowledged as a leader in global health and an associated professor in the health department at the University of Michigan and the School of Public Health at Tulane University. She's actively involved in research and global health training and STD, HIV, and has recently been appointed member of the National Academy of Medicine in the United States. She has become the first Peruvian professional to be appointed to this position. Professor Patricia, you have the floor, please.
Thank you so much. I just want to be sure that you can hear me well, the translators can hear me well. Yeah? Thank you. Okay, so let me share my presentation. First of all, I would like to thank you for the invitation to participate in this discussion about what is happening with COVID. I want to say also that I do not represent the Peruvian government. And although I have been, I was called as part of a group of advisors for scientific issues and innovation, I think this has been the hardest job in my life, because although we were there, actually the government was not really listening to the recommendations of the group of experts that they called, and eventually we decided to resign. So I will try to go through these different topics in the agenda and try to share my own view, my personal view of what has happened in Peru during COVID. Peru is a very diverse country with 33 million inhabitants. And it's a very centralized country because 1/3 of the population is in the capital city of Lima, which is a mega city. We were having a fast growth economy. The problem is that it has been based on informal or unregulated work. So we have more than 40% of people that are self-employed, which is the highest rates in the region. We also have a very weak social protection system, poor housing, and overcrowding. But one of the things that probably it's a little, I mean, I have seen so many things in common with the previous presentations, but one thing that has been also a big problem during these past 5 years in Peru has been the political crisis and the instability, which included the change of 11 ministers of health, about 5 or 6 during the pandemic. I already lost the count, and 4 presidents in just a matter of 5 years. So we have the opposition of the Congress to the president policies. The president was replaced. The Congress was dissolved in 2019. And just when the pandemic was started, we were having a new Congress coming out. So I don't want to make it complicated, but I mean, there have been so many changes of presidents and so many protests in the country. Then eventually we have a president that was the president of the Congress, really, Sagasti. And now in July 28th, we will have another change of government. So it has been a very difficult time in the middle of this sanitary emergency. Over that, the Peruvian health system is a fragmented health system that is under budget, with about 92% of the population served by the public sector, with unfortunately poor quality public services and with a very weak primary health care system. And according to the Global Health Security Index, that was a self-report, it was self-report in 2019, we already knew that we have deficiencies in terms of biosafety, laboratory systems, epidemiology workforce, and about emergency response plans. So one of the things that the country had to do was to start preparing early. And actually by February the 2nd, we had a COVID national plan for preparation and response. However, by that time, probably it was too late. When we were trying, although we were having the money, when we were trying to get or purchase protection equipment and supplies for the laboratory, it was impossible. By March 6th, we have the first confirmed case. And by March 15th, the president declared a state of national emergency and lockdown with very strict controls of citizens' movement, except to purchase food or pick up medicines and use. And also very early, there was this rule to use masks. You can see the military was in the streets, and remote work was introduced, and only workers from critical sectors were allowed to commute. Then the national borders were closed the following day, and the schools were also closed. And actually, we have and I'm not going to go into everything, but very early we have every single measure that other countries have done. We even started a quarantine hospital. However, I have to say that because it was called isolation hospital, nobody wanted to go. And when people was forced to go to these hospitals, they were just leaving. So one of the things that happened that was really critical at the very beginning of the pandemic was that, number one, we didn't have the laboratory capacities. Only the National Institute of Health was able to do, from the public sector, was able to do molecular testing. Unfortunately, the government didn't respond the way we were asking them, because although this was the only laboratory, we had, at least in most of the regions in Peru, we have 24 regions, we had academic laboratories that had the capacity to do molecular testing, but they were not included in the network for testing for the country. But the other problem was that there were no enough supplies. And so at that point, and I think we were one of the very few countries, very early in April, we decided to buy serologic tests, these rapid serologic tests. There were like 1.5 million just in April that arrived. After validating the test, because we have a study to validate it, it was implemented for the detection of cases. The idea was that to use this type of test, and if it was positive, we consider the person to have COVID. And if it was negative, people should be having a PCR. I mean, that was the algorithm that was supposed to be used, but the fact that the test was so easy, as you will see later on, make it so popular that we even started having like a black market of rapid tests. And unfortunately, the rapid test became the way of making the diagnosis, but also people started to feel that having a test meant that they were not sick and there was no risk of infection. So they had this false sense of security, which was really terrible. And every single policy of the country was based on the rapid serologic test. And finally, this is another thing that is interesting, is that we started to have a definition of confirmed infection, which is completely different from other countries. Any patient will be considered a confirmed case if they have a test that is positive to PCR or a serologic test with or without symptoms. And actually, most of our cases had been diagnosed with a serologic test. So this is what happened, okay? We had the first case, we started very early with the mandatory use of masks, and the cases started racing, and this was our first wave. There were some closures and some openings that they call the different economic stages of activities, okay? But eventually, we had our wave and kind of survived, but it was really critical. People were coming to the hospital at the last time. We didn't have enough oxygen, and our hospitals were completely overwhelmed. All the primary care centers were closed, and everything was done at hospitals, which was one of the biggest failures from my point of view. So this was the daily confirmed deaths in the first wave. And actually, everybody was talking about how high they were, and actually they were very high. But there were also, and this is an interesting thing, we started in 2016 a new system for online death certificates registration. And we started to improve it. I mean, I started this when I was a minister in 2016, and we continue following it. And in 2020, we proposed the government to use it, and it was used, and there were incentives also for physicians and for people to report deaths. People will receive money for the funeral if the death happening at hospitals or at home was registered in the system. So I think we have had a very good system for recording deaths almost at real time. So what happened after? Well, since we have all these rapid tests, we decided to do some serologic studies that were done in November 2020. And we found that about 40% of the population in Lima had detectable antibodies against SARS. And in areas like the jungle in Iquitos, almost 80%. So people started feeling that nothing was going to happen, that we were almost having herd immunity. And plus, we had all these changes of presidents and protests, etc. And a second wave started in December 2020. After these economic openings, the preparation for the holidays, the festivities, and because people were starting, and people never thought that because summer was coming, we were going to have this second wave. In June 2021, the National Institute, for the very first time, because as I said, our laboratory capacities were very limited, released the first data from a study of 1,700 samples, where they showed that we had a new variant, the variant Lambda, that represented about 71% of the cases. We had 14% of Gamma, and for the very first time, the Delta variant was found in the country. Actually, it was found in the southern part of Peru, and later on, we have found few cases of the Delta variant in Lima, but this has been just recently. This is what has happened, the first wave in 2020 and the second wave in 2021. And now we're using even antigenic tests to find patients. And right now we are seeing, although we have found the Delta variant recently, we have seen that the cases have been coming out. We have been able to do testing in about 15 million people. And these are the curves of the confirmed deaths. And unfortunately, this second wave has been even more terrible. People were dying inside the hospitals because of the lack of oxygen, on ventilators with no oxygen. And there have been all kinds of things associated with corruption, as you have heard before, corruption with oxygen, ICU beds, medications. And one thing that was also terrible is that we have the same issue as in Brazil, that the government decided to recommend packages of treatment with no scientific evidence, with hydroxychloroquine, azithromycin, ivermectin. And we have had also cases associated with this black fungus. And unfortunately, when you look not only at the numbers of deaths, but the excess mortality, you can see the red lines there. We are the champions of the world, which is one thing that is terrible. There have been other impacts. Although we have all these lockdowns, and I love what I heard from our colleagues from South Africa. Yeah, we also have this economic insurrection. People could not stay at home during the lockdowns, and they started coming out, and because they had to get the money in the streets in order to survive, because 72% of the population has this informal, unregulated economy. And that has probably increased at least 10 points. Employment fell 20%, the poverty rate has increased. And although the government tried launching a program of economic compensation to protect the vulnerable population and to support the businesses, they started some cash transfers, but everything was so delayed and we were not prepared. Our banking system was not prepared, and people were not used to do electronic transfers or electronic processes. Education has been also affected due to complete closure of schools and universities. We're still closed. Teleeducation strategies were developed a little before the pandemic, but however, the problem is that, and they were using internet, television, radio, etc. However, we have parts of the country, it's a country with lots of inequities, where it has been very difficult to reach students, and there has no formal evaluation of what has happened yet. So Peru's coronavirus response was right on time. We have done everything that was said. We even had hospitals for quarantine, and we tried to do things. But why we were hit so hard? Based on the comparison of deaths in 151 countries relative to the population, unfortunately, Peru is in the first position with 6,005 deaths per million. Okay. So I try to summarize here some of what I think are the most important things. Number one, the contextual factors, the poor housing, the overcrowding, the social norms, because people, in Latin America, we're used to live together. We have these extended families. We are close. It was so difficult for social distancing. And it was so difficult for people also to use the masks, informality, the politicized environment, the distrust of the government, and the slow governmental responses to support the population. And the result was that people were not following the lockdown. At some point during the pandemic, we have more people that were taken to the police station than the people that were infected, because people didn't care. Social distancing strategies were very difficult. Mask use was difficult, and there were so many difficulties isolating people isolating cases at home. We had families in one room with 15 people living there. We had a limited laboratory capacity and lack of supplies and PPEs, and that undermined the implementation of an adequate case identification tracing strategies. Just in this second wave, the government started creating these teams that were going door by door and were distributing the pulse oximeters. The problem is that people were not very well explained about the pulse oximeters, and people started thinking that pulse oximeters were for diagnosis. So there had been so many things that were not very clear in the communication too. The massive purchase and the use of serologic rapid tests was initially very helpful, but it was not good for early identification and isolation of cases. It induced also a delayed deployment of capacities for molecular testing because everybody was feeling so comfortable with it. It was overused. People felt that it was like a health certificate to have a serologic test that was negative, and it gave a false sense of security. Some people were taking serologic tests to have parties or to go to work and be all together without masks. Another factor is the weak health system. We unfortunately have a hospital-centered pandemic response. Primary care centers were closed. The government said that it was because of the lack of PPE and the risk for providers, but actually this lack of primary health approach or pre-hospital, pre-ICU approach caused the hospitals to overwhelm. We had no ICU beds, no oxygen, and other health problems were ignored. Although telemedicine started and has been used, but it hasn't been evaluated. The use of medications without evidence had been a big problem. There were treatment guidelines and scientists and experts, we were completely against it, but the government didn't listen. And they started distributing treatment packages door by door with hydroxychloroquine, azithromycin, and ivermectin. And that caused adverse events, toxicity, antimicrobial resistance, complications, and self-medication because people, if the government is doing it and they are not bringing it to my home, I will buy it. And at some point we ran out of lots of medication. There were no antibiotics because people were taking it. And they were taking it as if it was preventive. And it caused a false sense of security. There had been also a lack of communication campaign, inadequate information about public health measures, and unfortunately, there was no community involvement. And the government, instead of bringing everybody to the table, they were trying to do everything themselves. So the population was not following the lockdowns, the social distancing. The population was confused, and the community didn't feel that they were part of the response. So what about the COVID vaccine? Well, because of this political instability, because we are a small market, because of the bureaucracy, and probably because of the abusive conditions set by the companies also, and our poor experience of negotiation, we were very far behind on trying to access vaccines. We were able to sign a contract with COVAX, but COVAX had a very slow distribution. Although we have a national plan for prioritization in October 2020 with different phases, which means starting vaccinating the health providers, then some critical workers, and then people with more comorbidities and by ages, there were several adjustments that were done. The initial negotiations allowed us to buy the Sinopharm vaccine. Initially, we were told that we were going to buy 40 million doses, but eventually only 1.5 million doses arrived the country. The vaccination started in February, but it was very slow until June. That is when we have started catching up. Now we are at the level of vaccinating people that are 40 years and older, and we're using the Pfizer vaccine. The public are very receptive, and right now we have at least 3 million people that have received one dose. That means 9% of the population, about 4.38 million people that have received 2 doses. And that is because the transition government was able to sign some contracts with Pfizer and recently also with AstraZeneca. And apparently with the vaccines that COVAX is bringing, we are having right now more vaccines available. So you can see here, United Kingdom, United States, South America, Brazil there, and Peru, and you can see how we are catching up starting in June, and we hope it will go up. Even these weekends, we are having what we call the vacunathon, which is kind of like a campaign. So they are like 24 hours. Saturday and Sunday, the vaccinations areas are open to anybody who is lacking, for example, their second dose, so everybody can go or that they are on the right age. So anybody who is less than 40 can go at any time, even at midnight or any time. And we have seen, and this is things that we are showing, is that, for example, COVID mortality in physicians compared to general population really started to go down once the vaccines were given. And I guess we are used to trust vaccines, but with this type of data, people want to have vaccines and they are making queues from one day to the other in order to get vaccinated. So what are the conclusions and the lessons learned? Peru was having a very good economic situation. We had the money, we have the cushion money to have a good response. And actually we started early with the restriction and prevention measures. And several are still ongoing, but we have been hit very hard by the pandemic. And one of the things that I think has been critical are the contextual factors. As a country, we will need to redesign social protection strategies, address inequities, and work with vulnerable populations. But one thing that is very, very critical is political stability and clear leadership. I think that has been one of the things that had not allowed us to have a real good response in the country. We need to invest in strengthening health systems capacity. Our primary care system is really very weak. We lack ICU beds, and we knew that when we started, we have less than 500 beds for the country. Right now, we have almost 3,000 or 3,500. So we were able to increase them, but it was not enough. Oxygen, human resources, health information systems, and laboratory capacities are things that need to be addressed. Rapid tests were initially a useful alternative to the shortages of molecular testing in Peru, but contact tracing and isolation were not effective. So it's not just a matter of testing, but testing and having a good response. And to have a good response, we need to have the social protection strategies that will allow people to follow the rules. Decisions should be made on the best evidence available. We need science, we need implementation science, we need behavioral science, and we need the government to really understand that. For the lack of supplies, I think as a region, not only as a country, we need investments in technology, and we need to have some technological independence in the region. Effective communication and transparency is something else, and community engagement for public understanding, preparedness, and responses are critical. As a country, we have been a model for community health agents, but they were not included in the response, and I think that was a failure. And that's it. I'm looking forward for the questions, and thank you very much.
Thank you very much, Patricia. I think we again sadly see this universality of images that Sachi told us. I bring another similarity with Brazil, is the political crisis. Both Peru and Brazil had just lived a coup of state in similar ways just before epidemics hit the countries. I think this is part of the explanations of what we live today. I'd like to address all our participants, all our professors, the same question of how each of you see, one, the role of primary health care in vaccination in the next few months, and two, how do you see the behavior of epidemics in this next year? I would say year of some months ahead, that we can just feel the impact of vaccination and the possibility of getting to the threat of collective immune response. So I'll ask each of you in the same order we began. So beginning with Winnie about these questions. And while that, we also wait from questions from anyone by YouTube, by the chat.
So thank you very much. In the case of China, in terms of vaccination, China is not really relying on primary healthcare centers to do vaccination. It's a mass mobilization effort and using the community to mobilize. And there are these huge vaccination centers, or I mean, it's almost like what we see in Boston, doing it in Fenway Park, that kind of approach to get people to get mass vaccinated. And some of them are primary healthcare providers, some of them are not even that. They're just trained to do vaccination, and that's why they're doing it rather quickly. The problem with China is that many people have been vaccinated with Sinovac because they are producing two types. The first type, Sinopharm, has been exported. Sinovac is the one that is used to vaccinate its local people. And increasingly, there is evidence that it is actually not very protective against Delta. So to what extent China actually need to get people to do a third booster? And someone who is at the Center for Disease Control a few days ago was having dinner with my colleague. He even said maybe we need another 2 booster. So I think that's where science and implementation and government policy is not aligning. I think that's where China is a little bit falling short in terms of, yes, they're able to get a lot of people vaccinated, but are they vaccinating with the most effective vaccine? That's a slightly different question. In terms of behavior, I think that, I understand from other conversation and presentation that it is very hard to get people to wear masks, wearing it the right way. It is very hard to get people to go to test if they need to. It is very hard for people to do a lot of things, which is behavioral, right? If they need to be isolated, they actually do stay in isolation. I do not have a good scientific response. I do not think it is simply because Chinese are more obedient. I think, again, it is, if you would ask me, is 2 things. One is the way these information are communicated to people. It is not completely through the government. It is through the communities, the people that they already have been working with. And I tend to agree with Sue that yes, China was able to do it is because they already have that infrastructure. That community actually started in the 1960s, right? It's sort of part of that barefoot doctor system. That system doesn't work, but that sense of a community is still there. So they are the one who is doing most of the things that have an effect on behavior response, because behavioral response is just so hard to get the government to make change. It has to be the people around you whom you interact on a daily basis to do it. So what are those that are in Brazil or in other countries that you can mobilize would have to be really locally adapted.
Thank you, Professor Winnie. Sachit, would you please?
Yeah, thank you. India in particular has a very robust public health system that can deliver when it works. Vaccination campaigns in India, as also election ballots, have historically reached the farthest corners of India. The mechanism to get the vaccines to everyone in India exists. Vaccine procurement is the biggest challenge. Of course, in India, we're lagging behind. There are days when folks are trying to get the vaccines, but vaccines are not available and they have to wait. Vaccine hesitancy, the numbers are unclear. There is more vaccine hesitancy than there has been in the past, but globally this, is unfortunately a manufactured problem. And what we I think have to worry about is the impact that this vaccine hesitancy is going to have on childhood vaccines, where you typically did not have great amounts of vaccine hesitancy around the world, and whether there's going to be a spillover effect. In terms of behavior of the epidemic, I think vaccination is going to be our Achilles heel. If you look at these numbers, only 1% of people in low-income countries have received at least 1 dose, right? 70% of the world has not received a single dose. This is the opposite of where we need to be. This is sort of beyond science that I feel legitimately qualified to speak about. But if there are variants that weaken the efficacy of existing vaccines, we'll always be playing catch up. And as we have seen repeatedly, right, what we need to do is have community solidarity and a little bit of self-discipline. But the politicization of the public health response to the pandemic is, I think, the greatest barrier that all our societies are facing.
Thank you, Professor Sachit. So, Professor Susan, please.
Yeah, thank you. So I completely agree with my colleagues. I think in South Africa, what's been interesting is one of our provinces, which is the poorest and has very limited health services, not great health services, Limpopo, but they did the best when it came to vaccination, and that was a total mobilization process. So they basically went door to door, talked to people, got the local leaders vaccinated first, and so on. So I think that bringing in the primary healthcare sector is critical. But remembering one of the issues about primary healthcare, and I think one of my colleagues mentioned it, that during lockdown, people couldn't access. So all the childhood immunizations, we don't know what's happened to chronic illnesses. One of the benefits in South Africa around chronic illnesses is that we started this dispensing, auto dispensing, well, it had been started for HIV patients, but now people with chronic illnesses went on. So you can get your 3-month supply from a ATM type machine. So I think that's been good, but we don't want to overload the primary healthcare services so that women can't deliver happily and children won't get their vaccinations. I think the second question about the behavior of the epidemic and people's behavior in the epidemic is difficult. It's going to have to be, as people say, of course, vaccination is the answer, but it's going to have to get to a point where people, I think, will be wearing masks fairly permanently for quite a long time. It's going to become the norm. We're going to all feel comfortable wearing masks because that's how it is. And we're going to have to treat this epidemic like flu. And flu is not harmless by any means. People don't realize. I know in South Africa we have 11,000 deaths a year from flu. So I guess at some point it's going to normalize and become another flu.
Thank you very much. Professor Patricia, please.
Yeah, thank you so much. So I think there are so many similarities, right? Because the primary care centers have been closed, right now what they are trying to do is they are trying to rebuild their capacities to try to catch up on all the diseases and the vaccination that is around. Having said that, what happened in Peru is that what has been created, well, actually not created, it's like we're using the experience that we have with massive vaccination campaigns in this COVID one and making it even bigger. So we not only have the people that have been working in primary care, because we need some people staying at the centers, right? But we are also involving even military that had been trained on how to put the vaccines, okay? So when we have like a mixture, we have primary health centers that you can go to get vaccinated. And actually every Peruvian has a DNI, which is your national identification number, which is unique. So using the same system for voting, so people had been arranged depending on where you live, where you are supposed to go. But if for some reason you miss it, that's what we have now, these campaigns called vacunatones, which is like Saturday and Sunday open for you. And if you are in the right place, you can go. So we have a mass campaign plus some centers that are already working there but I don't think we can overwhelm the primary care system because it needs to start working again. One interesting thing that probably, we were looking at numbers right now. We were calculating the numbers of how many people had been vaccinated. We have reached about 80% of all the people that are 80 years and older so far, and about 70% of all the people that are 60 years and older. But what happened is that also, that population is, we're a younger population, so we still have to vaccinate all the rest. But what I'm trying to say is, we have about 30 to 40% of the people that are 40 years and older, but people are queuing, waiting for their vaccines. The problems have not been how to vaccinate or hesitancy, but the availability of vaccines, which I really hope, because supposedly we have signed all the contracts, etc. With the change of the government, this is not going to stop. Regarding the behavior of the epidemic, I completely agree. I think this is, and WHO has already said, this is going to become endemic. But the desperation of countries like mine, like South Africa, probably India, is that unless, and it should be the desperation of high-income countries too, unless everybody is vaccinated, maybe, because this is the risk, another variant will come out and we will need to start again doing all the vaccinations. Right now it looks like the vaccines are covering for the worst things, like the severe disease, but this may change, okay? And talking about the behavior of people, I think this is the moment in which people has to understand that vaccines are great, but they are not impenetrable, okay? And because of that, we still need to use masks. And I had a question for our Chinese colleague, because one of the things that I remember, and don't take me wrong, but every time when we were receiving Chinese tourists, they were using masks, okay, several times. So they were used to use masks. And people were, even in my country, seeing Chinese people with masks walking around, they were like, what do these people have? They are crazy, right? And that was before the pandemic. So I think another thing that has been important for you, probably, don't you think, has been for China, the experience of having SARS before, and MERS and all those things that we never thought were real in this part of the world, at least. And that has helped also to a better response. I guess you have good memory, or Chinese had good memory also, because that's what I fear. I fear that after this terrible event, people will forget, and with the next pandemic, we will not do things the way we are supposed to.
Thank you, Cristiana. Just a minute, Winnie, just a minute, because I have a similar question from Marcia Castro that is with us. So I ask Marcia to bring her question.
Winnie, you can answer first and then I'll ask the question.
My sense is that my question to you is yes and no, in the sense that, yes, I think their resistance to wearing masks might be smaller. But if you see how in China, even today, they are willing to put on a mask, they're not in crisis mode. I do think that without education, persuasion, they will be doing it. And I think part of the education and persuasion, which I think is very important, is the sense of what you are doing have an effect on your neighbors. I think that sense of the self and the community, it is essential, because people are not wearing it for just themselves. And same as the message that goes out to vaccination, it is not just about protecting yourself. There's also that sense of, as long as you do not get to this much percentage of herd immunity, basically the country will still need to be closed and all of that. So there is also that sense of you and the community. There's a sense of what you're doing has an effect on others as well. And I'm afraid that actually its effectiveness would vary by country. social value, the value of whether everything is just about oneself or whether people care about your actions' impact on the larger society. So,
okay, so let me follow with a question now, which has to do with you are all discussing. So communicating things, right? So you would imagine that in the middle of a pandemic, countries would organize a mass communication campaign to bring the right information to the population, right? Seems reasonable. And in the case of Brazil, we have a history of doing that. But of course, during this pandemic, that wasn't done alongside many different things were not done. So my question is sort of two-part. One is, was anything like a mass communication to sensitize the population, bring the information, get adherence to strategies, was it done in the countries you talked about? And the second thing is, I think we got a good mix of trying to use community health agents or whatever name is, but somebody there at the local level. And then the examples, and Patty, were very direct. They didn't involve community health agents. Brazil didn't involve either. So I don't know if there is some kind of role like this in South Africa or India. So why do you think that didn't happen? And I can give you one example in Brazil. Right in the beginning of the pandemic, there was a protocol issued that if you start reading the protocol, it says, well, this is what the community health agent should do. They shouldn't go to the houses. They should work in healthy units. And then if you keep reading it, it says the opposite. So it was so confusing. Nobody knew what to do. And because Brazil is big, we had some community health agents working with the support of different actors in the community and others that just went in an office and tried to reinvent their work. It was a mix, but basically they were not part of the response. So if you could talk a little bit about those two things, the mass communication and the role or the complete lack of a role of a local person in responding, but also bringing the information. Thank you. Any order, you can just...
Okay, can I start? Then I'm happy to start. So in terms of mass communication, there was some mass communication, but because communication is my kind of field, I was horrified at the lack of depth of it and also the lack of listening and testing. So people, if you don't test your communications, you don't know how you're coming across. And for me, that was the biggest problem. They just sent out messages randomly. I think that it also was very erratic. And even now, there's very little happening. You need constant reinforcement, communication, getting to people and listening to people. So for me, that has been a huge gap in South Africa. I think in terms of the community, we've got what you call community health workers. So the base on which we're starting is that we have, I think there's 600, no, I don't know how many, let me not say, but they are very poorly paid. They're not properly included in the health system. And when the government decided who were essential health workers who needed to be vaccinated, they were not included. So their use as vaccination agents was so limited. They weren't included. They were encouraged to go from house to house to reach people. But of course, it was dangerous. They didn't always have PPE. Yeah, it was a disaster.
Maybe. No, go ahead.
Please go ahead.
Go ahead.
Okay, so regarding mass communication, so this is something that, I mean, in general, not only mass communication, communication about the pandemic. In the country, the president, the second, I think, he decided to be himself who was giving the numbers and telling things, okay? And there was no campaign really at all. And actually, it was so interesting because without thinking about it, I ended up being in the TV, in the radio, explaining the journalists, trying to make things much more clear and trying to give messages. But it was not only me, it was like several experts trying to fill the hole, the gap of communication that was not there, okay? I mean, I have to tell you that I was invited. I even had a TV show, okay, a real show, 1 hour a day in the national TV channel, responding questions and social media, etc., about the pandemic, because there was nobody from the government doing that, okay? And that was in the first wave. In the second wave, I mean, even the private sector was offering the government to sit down and create a campaign. But I don't have any idea why this was not really thought about. I mean, we have very good experts about this. And eventually what happened is that they created messages that were also, as you said, erratic. They never tested them. And some of them were so crude that people could, I mean, you could see that people were saying like, I'd rather not see it, okay? This is terrible. And so they were so scary, some of them, or so complex that, and they were never really steady, okay? So basically, I think the communication, except for the media, I think the media in general, the TV, the press, etc., were trying to fill the gap that the government was not able to fill. And actually the experts, we were doing kind of the same thing, although we are not trained for this, okay? And so I think that has been a real big problem. And on the other hand, we have all these social media bringing all these fake news, myths, and other things. So it was very hard. Regarding the second thing, why the community health workers were not involved, okay? So one of the things is that community health workers here are not properly recognized by the government and they are not paid, okay? Although we were able to release a law, at least to have them recognized, and we have a database of all of them. But basically, they were completely ignored. Actually, all primary care was completely ignored. When I talked with the government why primary care was closed and why we were not including community health workers, the answer was we don't have enough PPEs. And we think that there is going to be more harm and we can handle everything through the hospitals, okay? And that proved completely wrong. So some of the municipalities, we have some examples of municipalities in certain places that organized themselves and started working and helping some communities, etc. But the problem is that that ended up just as little examples of something that didn't work. The policies didn't include at all community health workers. Everything was the hospital. So the policies were closing anything that had to do with primary care or things that were closer to the community. And I think it had to do also with fear, okay? So fear, maybe the lack of protection, and the fear had two things, okay? So one was the fear of the disease, and the other was the fear of the government from the unions, because the unions were really, so the unions of professionals, I mean, they were really also scared about the high rates of health professionals that were dying. And so it became a very complex situation too.
Thank you, Professor Sathi.
Thank you. I have to acknowledge again, just the universality of these problems. If I had walked into you speaking, not knowing what you were talking about, it could have been so many countries that we're representing here. I have 3 points to make about communication. Communication was very effective was effectively used in India for messages that the government wanted to communicate. And unfortunately, it ends up being the pandemic theater, right? So large brushstrokes that sort of look like sweeping interventions from the government are given most stage. The head of state has been on television a few times and enjoys, or at least in 2020, enjoyed vast popularity across India. People would do what the heads of government would ask them to do, including a one-day trial lockdown that he went on national television and asked people to do, and people voluntarily stayed at home. This was just a few days before the actual lockdown. Including peddling the digital contact tracing app, which had not been piloted, which had not been tested, which had not been validated. You have a head of state going on television, various arms of government, senior government representatives, right, encouraging people to use the digital contact tracing app. That same zeal has not been seen by heads of state asking people to mask. The masking experience, especially through Mushfiq's work, has shown that it is really important to get the local community representatives, people that individuals respect in their own microcosm, in their own society, to ask them to mask. After the erosion of trust in government in so many communities, it wasn't, the Bollywood actor masking that was going to have as much of an impact as the local imam in the mosque or the local village leader, both demonstrating masking by use and by example, but also encouraging people to mask. I want to acknowledge what the scientists have been through. I think we're learning the importance of translational science. Many of us who felt comfortable and thought it was appropriate for us to stick to the science and then leave advocacy to others. I think 2020 has shown that space gets filled up by folks that don't know or don't know much. And each of us, I think, has examples, as Patricia shared, of having spent so much of time on podcasts and op-eds. I've written more op-eds in 6 months last year than I have ever had in my professional career. And whether that is the most effective means of communication. And in India, it certainly is not, because we're a little, English-speaking bubble. We're still failing to communicate with a vast majority that are then consuming information through social media. I think this also raises questions about accountability. In many of our countries, people are jailed for saying things that may be inconvenient truths, right? For littler things. And yet there is no accountability for the misinformation that directly results in foisting such misery upon populations, right? And I think these are questions that the scientific community is going to have to engage with policymakers in terms of understanding what freedom of speech means in our various contexts and where what amounts to screaming fire in a theater. Community health workers have finally been used in India, and quite successfully. India has 1 million ASHA workers. They're India's community health workers, and several hundreds of thousands of others. Civil society organizations have mobilized to use ASHA workers. The Community Science Alliance that I talked about has really protocolized what the ASHA worker needs to do. And as all of us have acknowledged, distributing pulse oximeters doesn't cut it. We have to support these community health workers to walk, not that last mile, they're in the last mile, but those last 10 feet, right? Understand how to use that pulse oximeter, call someone every day, 2 or 3 times a day, understand what their oxygen saturations are, and then intervene upon it. And just those last few steps are not done because, again, that's the unsexy component, right? It's your grand sweeping distribution of pulse oximeters gets you the headlines. ASHA workers, calling 3 times a day to make sure that someone's actually paying attention to the oxygen saturation doesn't. And I think the cure is in the details. And I think we need to do a better job of that universally. Thank you again.
I'll just be very quick since there's limited time. China definitely, for things that they want to communicate, they definitely have a very effective communication strategy. And I think that's partly the Communist Party's strength. The propaganda engine, if they want to use it, it is just very powerful. every state, every lesson, every advice is all cast in these 3-character sentences that rhymes, and it is on the wall, it is in the television, it's through radio, it's on your app, and children, they would have video which is produced specifically for children in cartoons. There are other videos which is for different kind of population. You don't need to read, you just need to understand that 4-character. So that's done really well. However, do remember in the beginning stage when the government was trying to deny the situation and therefore do not have the right information sent to the people, and yet there is this doctor who actually whose communication with his own colleagues were leaked. That was the period of a month that the whole government and the party was actually seriously threatened in terms of its legitimacy. So yes, communication is important, but do it right, because if you don't do it right, you can be in serious trouble too.
Thank you. I'll get to Vera, who asked for the word.
Can you hear me?
Yeah.
Okay. So thank you, all of you, for the wonderful panel we had. And again, for the quick and recent invitation that you accepted in this moment of the pandemic and summer and winter here, right? Break. I got many comments that we don't have time to discuss right now about the consultancy firms giving more advice than the scientists everywhere, and how much did it impacted on the hospitals, on the curves, the models and curves that doesn't say anything, people who does not understand anything about public health and community health and social and collective health, right? And the hospital-centered response that we got without using our knowledge on the importance of community health, primary health care, and et cetera, from other types, right? Also, just to stress and invite you already to indicate good people for the third conference that we are getting, that will focus more directly or more we'll have the focus on behavior, individual responses and individual vulnerability, sex in the pandemic, and the synergy of the pandemics, right? So if you have any suggestion for us from the people you know from the BRICS, right? As we used to call it years ago, from your countries, please let us know. And ventilation, yes, it's been a problem. Nobody is including ventilation. Sue is totally right? And I just wanted to, after that, invite all the audience that we have in YouTube to come back at 2:00 to see the next sessions of today, which is the long-term impact of the pandemic with Professor Noreen Goldman from Princeton University, Cássio Turra from UFMG, Professor Aloysio Segurado, who is with us in this room, and the moderator will be Adriano Massoud, who was in Cambridge and Harvard for a long time and now is at FGV. And finishing with a wonderful keynote speak by David Williams from the Harvard School of Public Health on race and COVID mortality in the US and the UK, moderated again by dear Marcia Castro, who I thank again for your support and presence today. So thank you very much. I hope to get input from you for the next one. And see you.